Thank you for joining us for day 2 of our National Alzheimer Summit. If you missed any of the first day's events, all of the sessions are available to watch on demand on our website at allsummit.org. Now here's Ken Sella to introduce our first speaker, Ken Dychtwald.
Hello, and thank you for having me today. At Edward Jones, the relationships we build with our clients are one of the cornerstones of our unique approach to investing. Developing these relationships requires us to deeply understand those we serve and the challenges they face as they age. Alzheimer's disease is a public health crisis and a leading cause of death in the United States. Today, more than 6 million Americans are living with the disease, including an estimated 300,000 Edward Jones clients. Alzheimer's disease destroys not just health and wealth, but the relationships and memories of the families that we serve. It's an expensive disease that can cost people their retirement, money saved for their grandchildren's college, or their children's inheritance. And this is the reason we've joined the fight to end Alzheimer's through our alliance with Alzheimer's Association, and why we're sponsoring this important session today with Us Against Alzheimer's. It's also why we've partnered with AgeWave to gain meaningful insights in today's investors through research that helps us understand how, on a broad scale, people are viewing retirement today and what forces are reshaping how people prepare for this important life stage. Through our research, we've uncovered a new and holistic framework that includes 4 central pillars for living well in retirement: health, family, purpose, and finances. Each of them stands on their own, but they also intersect with each other a lot, and each of the 4 plays a role in fulfilling a wonderful retirement. With me today to share more about both opportunities and the challenges of emerging longevity landscape is Ken Dychtwald, the founder and CEO of AgeWave. Ken is one of North America's foremost visionaries and original thinkers regarding the lifestyle, healthcare, economic, and workforce implications of the AgeWave. He is a psychologist, gerontologist, and an author of 19 books. Please welcome Dr. Ken Dychtwald.
Thank you, Ken, and a big thank you to not only you, but all the folks at Edward Jones who are making such a massive commitment to both helping families who are grappling with a loved one with Alzheimer's, and also doing everything you can do as a company to support organizations to wipe this disease out. So I've got a lot to cover in the few minutes we've got to kick off this day, and I'm honored to be a part of Us Against Alzheimer's. I've been for a long while and friends and partners with George Vradenburg, but I'm going to ask you a favor. I'm going to ask you to take all the things you currently think about this disease and don't think for a minute about all the spectacular bioscientists and physicians and experts you're going to be hearing about, but allow me to tell you a slightly different story about what's happening relative to this disease at this moment in history. And I'm going to see if I can turn over some angles that maybe you haven't thought about before. So first, we've been searching for the fountain of health as long as humans have been getting older. And what I'm struck by is the fact that folks think this is sort of a new adventure. Go back thousands of years to the basis of Taoism. And the intent was to not just achieve some sort of enlightenment, but to try to ward off aging itself. And then along came the alchemists centuries ago who were trying to rid the body of its impurities. And then, of course, as emperors and kings and queens found their bodies aching and ailing and getting old, they sent off explorers to try to find fountains of youth. Truth of it is that most of that didn't lead to anything other than a mix in geopolitics. But it was the beginning of the 20th century with the arrival of public health departments, where for the first time we began to make a dent in the diseases that used to take people's lives and cause us to not live very long. And then, a few decades later, the extraordinary arrival of antibiotics and the availability of penicillin began to save lives and extend longevity. Now, let me build on that. Some of you may not know what this is a picture of. It's a picture of a ward filled with iron lungs, with people in those compartments with poliomyelitis. And back in the 1940s, when polio was rampant folks thought, boy, we're going to need more and more iron lungs in the future. And wouldn't it be great if we can make them lighter and more mobile? But then along came Jonas Salk and Dr. Sabin, and they decided, no, we got to end this disease. And so here's George Vradenburg as a little boy getting his polio vaccine. This was 1953, of course. And all of a sudden, a disease was largely put down. Now, breakthroughs in science didn't always go in a straight line. This was the 1950s and even the 1960s when the advertising campaigns for cigarettes included doctors saying that more doctors smoke Camels. So we have to be careful. Not every bit of progress in medicine or bioscience is good. Some of it is kind of nutty, and some of it we only learn years later was a mistake. But the progress continued with regard to healthy aging and healthy longevity. Before you knew it, in the 1980s and 90s, we began to introduce the idea of self-care in a serious way. We began to study the effects of exercise and sleep and proper nutrition. And then, of course, we had the breakthroughs that led to our ability to crack the genetic code. And an extraordinary pharmacopoeia simultaneously was emerging. So this searching for the fountain of health has really been gaining steam in the last few decades. I would say that one of the effects of this horrible pandemic we've lived through is that it accelerated our thinking about acceleration itself. How fast can we get breakthroughs? How fast can science be pushed? How fast can scientists work to get their progress not incremental, but possibly exponential? Now, this is a chart of the average life expectancy at birth over the past 1,000 years to the year 2020, right before the pandemic actually began shortening lives by a couple of years. But it was moved up to about 78.5. And what I'm continually struck by, having been studying these issues now for 48 years, is that throughout most of history, people didn't age, they died. So back in the 18th century, we weren't worried about age-related diseases because there were so few older people. Couples didn't say, gee, honey, what would you like to do in retirement? Because you weren't going to live that long. But because of the breakthroughs that I just dashed through, one of the effects of that is that more and more and more people are going to live longer and longer and longer. Now take a look with me at this chart of life expectancy over the past 100,000 years. And medical anthropologists now tell us something quite extraordinary, which is that throughout 99% of human history, the average life expectancy at birth was under 18. Now, there have always been some 60 and 80 and 90-year-olds, but very few. So we really didn't need to concern ourselves with the hopes, the desires, the attitudes of older people. And we also really didn't concern ourselves with the diseases that prey on the old. Keep that in mind. Right now, 2/3 of all the people who have ever lived past 65 in the entire history of the world are alive today. And this longevity revolution is not over. It's just beginning. And occasionally people say to me, oh, I think I've seen something about the future of aging. You know, maybe it's new tech. Maybe it's all sorts of wild things that guys like Elon Musk are dreaming up, or Jeff Bezos. But let me tell you that I think one of the mistakes we make is that when we envision the future, we envision kind of a Jetsons future. Young, cool, attractive people in tech, advancing tech. This may or may not be a picture of the future, but I actually do have a picture of the future, and if you're ready, I'm going to show it to you. So fasten your seatbelts. Here it comes. So I saw this picture a few years ago, and when it was taken, this little guy, Bradley, was 3. Sitting next to Bradley is his mom, Christina. She's 27. Standing up behind them is Kathy, the grandmother, who's 49. Next to the grandmother is the great-grandfather, Bob, who's 73. Across from him is Kitty, the great-great-grandmother, who's 95. And over on the side is Sarah Knaus, the great-great-great-grandmother at 118. A 6-generation family. This is the future. And so, for example, when I hear people talk about the balance between young and old, you know, that's very mid-20th century. we have to begin thinking of 6 generations alive at once, each wanting their piece of the pie, each wanting their share of health resources, medical science, education, public good, and each playing a role in the modern society. Let me add another piece to this puzzle. The kind of wild and crazy baby boom that appeared after World War II is now becoming an age wave. If you look at the 1950s, and this is a demographic portrait of each of the age groups, and it shows you which group grew or shrank by how much during the 1950s. So this baby boom clearly indicated it would have been a good time to have been in pediatric medicine or baby products or suburban homes or even life insurance. But look at what's coming. Between 2020 and 2040, the massive growth in the United States and pretty well all the developed countries of the world is not going to come from there being more children decade over decade, but more older people. And so everything pertaining to older people, what they want to eat, where they live, what their problems are with isolation, what happens to their bodies, are going to become the focus of our lives, whether you like it or not. And I'm always intrigued. People say, what are we going to do with all those old people in the future? You're going to be one of the old people in the future. So what are we going to do with us in the years to come? One of the biggest challenges has to do with the fact that while we've been attempting to increase lifespan, to improve longevity, we've done a pretty miserable job of matching our health span to our lifespan. And so as we grow older, there are all sorts of problems that occur: arthritis, varicosity of the veins, aches and pains in the joints, orthopedic problems, and I could just really ruin the whole day for everyone here. As we grow older, it seems that our bodies increasingly struggle. Now, is that necessary? Is that just the way of life? So, more and more of us now in the field of geroscience are thinking about this. And what we're learning is that there's lifespan. And by the way, the United States, if you look at this chart, is very middling. There are 33 countries in the world that live longer than we do. Many live half a decade longer than we do. So we shouldn't be so proud of our longevity here in the United States. But even more troublesome is the fact that our health spans, the number of years that we will live with vitality and well-being, are only a percentage of that lifespan. And as you can see with the US, we spend a lot of years sick. Now, I'm going to trouble you with the next few slides. I hope to trouble you because I'm troubled by it. This is a chart that shows the different countries in the world and how much each country spends on healthcare per capita. So we can be very proud, I guess, that we've made spending money on healthcare such a high priority because we spend more than any country in the world. However, are we getting healthy people as an outcome? No, we're not. If you look at the global life expectancy at birth, we are way at the low end of success on this. But even worse, if you look at health span, country by country, United States does miserably. So just a few months ago, I had the good fortune of speaking at a conference with pension fund managers from all over the Americas. And I asked them kind of a live poll. So these were people in their 30s and 40s and 50s, highly educated, access to information, probably had access to good health care, or so they thought. But I asked them in a live poll, which later life disabling condition scares you the most? Boom. What do they say? Alzheimer's. So yeah, I understand that we live in a world in which things like cancer and heart disease and stroke and diabetes and arthritis are terrifying and problematic. But as we age as a nation, Alzheimer's, which takes down 1 in 3 people over the age of 85, it may actually turn out to be 1 in 2 when you add in some of the other dementias like vascular, Lewy body, and percussive dementias. Alzheimer's could very well turn out to be the biggest challenge in the decades in front of us as a result of our ineffective healthcare system combined with our greater longevity. I also want to point out that although there's been a little bit of progress with regard to treatment, aducanumab from Biogen, right now the disease is 100% incurable and 100% fatal. And I want to point out that it's not just some of those other people who catch this disease. It was Ronald Reagan and Margaret Thatcher. It's Jimmy Stewart. It was Rosa Parks, Mort Zuckerman, my mom. There was a film that came out about a year or so ago about Bill Gates' brain, and this is a tiny little clip from that.
Bill Gates, what's your favorite animal?
Dog.
What's your favorite food?
Hamburger.
What do you eat for breakfast?
Nothing.
What is your worst fear?
I don't want my brain to stop working.
So why is Gates so concerned about Alzheimer's? Because he's getting older, and his father died with Alzheimer's. Hey, Trump's father died with Alzheimer's. He never mentions that, but it's true. My mom died with Alzheimer's. My wife's mom died with Alzheimer's. More and more, as our parents or as we are growing older, we're beginning to realize that this disease of the aging brain, yes, some people who are younger are affected, but primarily it's older people. It's a disease that preys on the aging brain. If we don't wipe it out, it's going to wipe us out. The economic impact could be complete devastation to national economies. It could be complete devastation to families and individuals. Gates people figured out that folks with Alzheimer's spend 5 times more on healthcare than those without. In fact, Alzheimer's could become the sinkhole of the 21st century. So what do we need to do? We need to create a path to healthy longevity. We need to have doctors who are trained and skilled in dealing with older adults for all the conditions they might have, but particularly brain health. How are we doing? Badly. We've got 126 medical schools. There's only 16 departments of geriatrics. Most doctors and nurses are coming out of their programs without learning the basics about how to care for older adults or the basics of how to deal with aging brains. The numbers are crazy because we've got more than 55,000 pediatricians in America and less than 5,000 geriatricians. Maybe it's because of the way we've constructed our economics, which is foolhardy. We pay geriatricians far less than we pay plastic surgeons. Excuse me, but what's wrong with us? Next, we need precision wellness and self-care. To tell people to go out and exercise or eat a healthy diet is far too confusing. You go to the average drugstore and all the vitamins are organized alphabetically, which is completely dysfunctional and not helpful. How about in Japan, though? They've made some progress. This is Toto. It's a biolab in your home toilet, so it can indicate to you on a daily basis what vitamins and supplements and foods and exercise regime might be better for your biometrics. I personally am taken by Waze, the idea that you can, in real time using AI, derive a path that's efficient, cost efficient, and will get you where you want to go. Maybe we need a health Waze so that each of us can be guided to the best 100 or 110-year-old version of each of us with guidance about food, supplements, exercise, and medical care. We need scientific breakthroughs. What is wrong with us? If you look at how we spend money, what are our priorities as a country? Yikes! What is wrong with us that we don't invest in the medical research that could wipe out the diseases so that we can live long, healthy, productive, contributing lives? Now, someone said to me just a few days ago, Ken, it's great to see that you're getting on this Alzheimer's bandwagon. Let me take you back to 1995 to the White House Conference on Aging. I had a great speaking slot. It was Clinton, Gore, then me. Here's a few moments from that.
We've got to fund a great deal of research. Please, I would hope that the future legacy to our children is not 12 million Alzheimer's patients. Although we need palliative and adult daycare, we need enormous amounts of money so that Alzheimer's, so that cancer, breast cancer, prostate cancer, arthritis, diabetes, osteoporosis will be diseases that have an end to them. This will not happen unless we fund research.
You know, I've watched every single presidential debate for the past 20 years, both sides of the aisle, and this has not been talked about. What is wrong with the media that they don't ask questions about this disease, which will become the sinkhole of the 21st century unless we beat it? Now, there are progress territories taking place. More and more science is creeping along. Yes, we've quadrupled the amount of federal funding for Alzheimer's research, but we probably need to multiply it by 50. But there are some areas that are intriguing. We're seeing about 25 drugs right now that are coming to market that claim to be able to slow down or even reverse aging. What about CRISPR? Are we going to see in the next decade breakthroughs that allow us to rewrite our genetic code so that we can write cancer out of the human experience? We can write diabetes out of the human experience, and maybe we can write Alzheimer's out of our lives. I saw recently that scientists discovered the genetic code that makes jellyfish immortal. Well, maybe we can learn about their genetic makeup and transform our genetic makeup so that we can live long, healthy, productive lives. As an example of another area, it may not just be pharmaceuticals or genetic manipulation. It may be focused ultrasound, which is a technology whereby in MRI chambers, sound is directed to be able to eliminate the disease and leave adjacent tissue untouched, which would render chemotherapy and radiation and surgery obsolete. What's the principle? Multiple beams, profoundly and precisely targeting a point of convergence, which could be 1/10 the size of a blood cell. Here's an example of a gentleman with essential tremor. He's awake, there's no anesthesia, there's no incisions, no burr holes, no electrodes, multiple treatments through focused ultrasound, same man. I'm taken by the recent announcement of the creation of ARPA-H, like DARPA, Advanced Research Projects Agency, to try to come to leapfrogging breakthroughs in health. And from what I understand, Alzheimer's will be a key focus, which would be terrific. What's the punchline? The punchline is we must match health span to lifespan so that your loved ones don't find themselves like my mom living their final years in a crib wearing a diaper. We must match health span to lifespan so that we don't drain our economy. We must match our health span to lifespan so that 100,000 years of human growth and evolution doesn't wind up in a dark story of millions and tens of millions of people losing their way, losing their minds. We must match brain span to lifespan. Some people say, oh, that's so hard, that's too hard, let's create a new game app so we can bemuse ourselves. Well, let me remind you that Abraham Lincoln called for a transcontinental railroad, got it done in 7 years. The Panama Canal was championed by Theodore Roosevelt, got it done in 10 years. The Manhattan Project, wow, that's a fairly sophisticated exercise, got it done in 6 years. The Apollo program, championed by John F. Kennedy, in these few seconds, got it done in 8 years. Watch these few seconds.
Now it is time to take longer strides. Time for a great new American enterprise. I believe that this nation should commit itself to achieving the goal, before this decade is out, of landing a man on the moon and returning him safely to the earth.
And we did it. And the Human Genome Project, Bill Clinton championed that, 10 years. What do we need? We need a scientific grand concerto, not just one bioscientist, not just one pharmaceutical company, not just one nutraceutical company, but we need a grand concerto that's orchestrated to create healthy longevity, not just for the billionaires, but for everyone. You guys are going to hear a lot of great presentations throughout the rest of this meeting. I wish you all the best in your interest, but I would say we've got to beat this disease before it beats us. Thank you.
Thank you, Ken. In just a few moments at 1:30 Eastern, we'll have today's first town hall focused on prevention. Our next panel, The Lifestyle Prescription, Delaying and Preventing ADRD Through Behavior Change, will talk about the importance of reducing the risk of dementia and Alzheimer's and how to get people to take action. We'll explore the science behind risk reduction and lifestyle changes people can make to promote their own brain health. Here's our moderator, Mark Middleton, founder and CEO of Growing Bolder.
Good afternoon and welcome to this live session that's dedicated to helping everyone celebrate the blessing of growing older, to maximize the opportunities of an entirely new life stage and to look at aging through a lens of purpose and possibility instead of simply loss and limitation. And of course, the most important key to all of that is lifestyle, the daily choices that we all make. We've heard from Ken Dychtwald and others at this summit that Alzheimer's disease is a public health crisis that just continues to grow, with nearly 14 million people expected to be diagnosed by 2050. And women and communities of color do bear a disproportionate burden, with women now making up 2/3 of all Alzheimer's cases. And by 2030, nearly 40% of all Americans living with Alzheimer's will be Black or Latino. And while there is not yet a cure, we do know with scientific certainty that cognitive decline is not inevitable. Working together as patients, as families, as physicians, and as policymakers, we can begin taking some aggressive steps to not just reverse the current trend, but ultimately to stop this dreaded disease. And folks, I got to tell you, this is not just Pollyanna-ish wishful thinking. The latest research, which we're going to share today, is that if we reduce the prevalence of 10 specific risk factors by just 15% each decade, as many as 1.2 million fewer people will be living with Alzheimer's and related dementias by 2050. These people are you and me. They're our families. And by the way, if we had hit that number in 2020, nearly 500,000 fewer families would be living with dementia today. So what are these modifiable risk factors? You guys know them well. We'll talk about them today, but these are things like diabetes, obesity, high blood pressure, physical inactivity, poor diet, poor sleep, tobacco use, and excessive alcohol use. These are things that we can control through lifestyle change. And if we can do that, we can maintain our cognitive capacity. We can keep our brain healthy. We can increase our lifespan, but more importantly than that, our health span as well. Today, we're going to hear from some of the world's top experts about these lifestyle changes. We're going to hear what's possible. We're going to learn what challenges we need to overcome and how we can all make progress together. And we hope to have time to answer some of your questions as well. So allow me to introduce each member of our esteemed panel and ask them to make an opening statement. First up is Dr. Karen Hacker, the director of the CDC National Center for Chronic Disease Prevention and Health Promotion. Dr. Hacker oversees more than 1,000 staff, all dedicated to preventing chronic diseases and promoting health across the lifespan. And among other important duties, she leads agency efforts to address the social determinants of health. Dr. Hacker, take it away.
Thanks so much. And I'm really honored to be here today with this audience and to be working on the shared goal of helping millions of Americans understand and manage and reduce the risk of Alzheimer's disease and related dementias. I want to highlight the work of CDC's Alzheimer's disease program and the work of all of our partners, many of whom are here today. Our funded partners are focusing their work to shore up the public health infrastructure for Alzheimer's disease and other dementias through the National Healthy Brain Initiative and the BOLD Infrastructure for Alzheimer's Act, which includes the BOLD Public Health Programs and the BOLD Public Health Centers of Excellence. Alzheimer's disease and related dementia, as you have already heard, are a growing systemic threat. And based on what we know, what keeps the brain healthy turns out to be pretty similar to what keeps the heart and the rest of the body healthy. Emerging evidence is now suggesting that small changes like lifestyle modification and managing chronic diseases like diabetes and obesity can really help with brain health. So CDC's data is suggesting that correspondence between several modifiable risk factors may actually have an influence on the risk of cognitive decline. So with your help and the help of our funded partners, we can reduce the risk, we can increase early detection and diagnosis, we can support caregivers and help reduce unnecessary hospitalizations. We're committed at CDC to using a public health approach to promote risk reduction for cognitive decline and Alzheimer's disease and related dementias. And this includes supporting interventions that reduce the barriers by addressing the social determinants of health. These are the factors that are outside of health systems that actually contribute dramatically to our health outcomes. And we're really committed to doing this, particularly in communities that are bearing the greatest burden. So we view our social determinants of health work as a pathway to addressing the problem of health disparities. And the goal is to achieve health equity in our work and reduce the risk factors for ADRD through behavioral change.
Thank you, Dr. Hacker. Folks, this is not rocket scientist, but we do have a scientist with us today. On our panel is Dr. Rock Neonogo. He's the assistant professor, Department of Epidemiology, Fielding School of Public Health, University of California, Los Angeles. And Dr. Neonogo's work investigates the impact of lifestyle, metabolic, and social interventions in preventing chronic diseases, the ones we're talking about: obesity, diabetes, Alzheimer's disease, and other dementias, and then translating that evidence into effective clinical, public health, and policy interventions. In his recent work, he investigated the importance of modifiable risk factors for Alzheimer's disease and other dementias. Dr. Neonogo, your opening statement, sir.
Thank you very much, Mark, and thank you everyone for having me here. I'm very honored to be here. So we know today that engaging in a healthy lifestyle, like Karen was saying, such as eating healthy, exercising, and maintaining a healthy weight is really important for preventing chronic disease such as heart disease and type 2 diabetes. What was less known, or at least what has been known within the last decade or so, is how these risk factors actually relate to Alzheimer's disease and other dementias. And this is what my research lab at UCLA, as well as other colleagues, have been able to focus within the last, within some time ago. And there are three main things that I wanted to highlight. Like, the first thing is, what is good for the heart is also good for the brain. We found that within our studies, for example, maintaining a healthy weight was actually one of the most important things you can do to actually reduce your risk of Alzheimer's disease and other dementia. Second, the prevalence of actually a lot of risk factors have actually changed over time. One example is midlife obesity, which has the prevalence has actually doubled, more than double actually within the last decade. It was about 13%, and now it's about 26 and 36%, in 2018, which means it's very important to tackle. Thirdly, the relative difference in the proportion of Alzheimer's disease that are related to some of these risk factors actually differ by different subgroups defined by race and ethnicity. For example, midlife obesity was really important for Blacks as well as whites. And it was also physical inactivity was important for Asian Americans, for example. So this actually gives us an opportunity to tailor and target intervention within different subpopulations. So I think within the next couple of minutes, we'll talk about some of these things in detail.
Thank you, Dr. Neonogo. And rounding out our panel today is Susan Benegas. She's the executive director of the American College of Lifestyle Medicine, which now has nearly 9,000 members. Ms. Benegas leads a staff of 40, overseeing the effort to transform health and actually to redefine healthcare, and not just here in the U.S., but around the world through her work with the Lifestyle Medicine Global Alliance. She is also an author and a much in-demand international speaker. Ms. Benegas, take it away.
Thank you, Mark. It's such a pleasure to be here today, and sincere thanks to UsAgainstAlzheimer's for the tremendous work they're doing and shining a bright light on this. Truly, it's a pandemic that we face of Alzheimer's. And Mark, in your opening comments, you talked about the upward trajectory. You know, we already have 6.5 million people, 65 plus, who've already been diagnosed with the disease in the United States. And when we look at the economic toll, you were talking about statistics and trends that if we stay on the current trajectory, by 2040, 2050, we will spend in direct costs alone over $1 trillion in treating Alzheimer's. Yet, the best news that any of us could hear, and based on the work of some of our members and leading researchers in this field, Dean and Aisha Shirzai, Dr. Dean Ornish, is that as much as 90% of Alzheimer's is preventable. And in the balance of that 10%, much of that is to be able to dramatically delay the onset. And it's as much about adding years to life, but truly adding life to years, ensuring that those lives are vibrant and cognitively healthy. And so the leading preventer is lifestyle intervention. It's evidence-based therapeutic lifestyle intervention to prevent Alzheimer's, knowing that 90%, as much as 90% is preventable. That is great news, but it means that we must take decisive action. And so, as you said, I serve as executive director of the American College of Lifestyle Medicine. It's a role I've had for nearly 9 years. ACLM is the nation's medical professional association that represents physicians, and also allied health professionals who are dedicated to treating root causes of disease, to focus on prevention, as well as for many of the chronic conditions, heart disease, type 2 diabetes. Evidence strongly shows that therapeutic lifestyle intervention can prevent and often even reverse these conditions. Where Alzheimer's is concerned, it's much more about the prevention of it, of course. And so our first and foremost priority is to fill the gaping void of lifestyle medicine in medical education. So that's where we invest heavily, and we're on a mission to do that because we need all of our physicians and medical professionals who have unfortunately not had the benefit of being trained in therapeutic lifestyle intervention as part of their traditional medical education by and large. So we are addressing that across the entire education continuum, from undergraduate medical education to graduate medical education, all the way through to continuing medical education. As the need is so urgent, we must reach those already practicing so they know and understand the evidence to use lifestyle, what people are eating, how they're moving, how they're sleeping, how they're thinking, to be able to prevent disease, to protect their health, and to even fight disease.
You know, given what's at stake for us individually, for us as families, and for us, Susan, as you point out, as an entire culture, I don't know if there's a more important conversation that we all can be having than the one we're having right now. So let's get with it. Let me pose the first question to Dr. Hacker. You know, obviously, we all know that behavior change is hard, but we also know that our symptoms and even our culture and some of our communities don't always support us in making those healthy choices. So, Dr. Hacker, can you share with us the interconnectivity between the known risk factors for dementia, some of the ones we've already mentioned, and what's often referred to, in fact, it's been mentioned a couple of times already, the social determinants that impact our health? What's that interconnection about?
Sure, and you're helping me out a lot there, Mark, because I think first and foremost, we need to talk about the fact that dementia care and support services really vary pretty widely, depending on your race, your ethnicity, where you live, and your social and economic factors. But then there's also stigma and cultural differences and awareness and just understanding what Alzheimer's disease is. And all of these can be factors that lead to health disparities. We also know that there's a lot of disparities and a lot of inequities in even how people get a diagnosis or manage their disease, and even their ability to get high quality care. So about 95% of older adults with Alzheimer's disease also have multiple chronic conditions. And with that, those conditions, we know that some of those are driven by these social determinants, right? So if you need to exercise and you don't have any access to places that are safe and available to exercise, or you don't have access to healthy food, so how can you possibly have a diet that won't contribute to these diet-related diseases? And we do know that Black and Latino patients are at greater risk for ADRD than their white counterparts. And some of that is because of these social determinants. And as I said, literally where you live. So as we really begin to learn more about those contributors, then the question becomes, how do we start to ameliorate them? How do we get communities mobilized to start seriously considering what they can do about these? How do we start to increase social connectedness, particularly for elderly patients, and really begin to make sure that the healthiest opportunities are opportunities that everyone can take advantage of? Now, that is not the simplest thing in the world, and we really do need collaboration on multiple levels to really get that work done.
Susan, trite but true, zip code more important than genetic code now to our overall health.
Well, yes, and we have Dr. Jason Purnell, who has been with St. Louis University, to thank for really being the first to shine that light on the zip code does influence greatly one's health outcome. And yet we really champion the fact that, yeah, there are social determinants of health. These are influencers, but everyone can be educated, equipped, and empowered with the adequate support to overcome. And so this is true. And when we know, it boils down to something very, very simple. This is simple, and it can be, as in a recent conversation I was having with Doctors Dean and Aisha Shirzai, that if one simply consumes 2 servings of greens a day, on average, that will add is 10 to 12 years of vital cognitive health to their life. Taking a brisk walk, 20 to 30 minutes a day can reduce the risk of Alzheimer's by 40%. Now, there are these issues that are real that we are all working very hard to address. Some of them are, unsafe streets and food deserts. And I was at the lake recently, didn't have a grocery store nearby. There was a dollar store near. This was down in southern Missouri. And I went in and I was able to buy frozen vegetables and canned beans. This wasn't expensive. And so there are ways to address this and to empower people. And but we have to be very cognizant of the challenges that many face. But it can be as simple as running in place, doing exercise with your, in front of your television screen, and frozen vegetables, while, fresh and organic may be optimal, that is not attainable for everyone. So there are alternatives and ways to take steps in a positive direction. And but we do need to educate, equip, and empower people. And we need to realize that we do have a glaring lack of food, health, and lifestyle literacy in this country that we definitely need to address collectively.
And Dr. Nyanogo, I think we all owe you a great gratitude of thanks, because your research has not just been fascinating, it has been illuminating, it's been validating, it's proving what I think all of us have been saying for a while, but now we can back it up with your research. You have proven that there's a modifiable list of risk factors for Alzheimer's disease and other dementias, things that we can change that will reduce our risk, but ones that are most prominent, most damaging, and therefore probably most important to change have actually changed themselves over the past decade. Why is that, and what are the most important risk factors for us to be aware of today?
Thanks, Mark. And just following up on what the great speakers have also said, I also want to highlight that this research has been conducted with the help and inspiration of Dr. Deborah Barnes from UCSF, and who has actually led the study as well. But we did conduct a study about 10 years ago, and actually Dr. Deborah Barnes actually conducted a study about 10 years ago, trying to investigate and find which modifiable risk factors were associated with Alzheimer's disease, things like midlife obesity, midlife hypertension, type 2 diabetes, smoking, depression, hearing loss. And we found actually that some of these risk factors today actually have changed. About 10 years ago, it used to be smoking, depression, and physical inactivity that were actually the major risk factors that were associated with Alzheimer's disease and dementia. Today, as Mark mentioned, midlife obesity is the most important thing that we have to really think about when it comes to type 2 Alzheimer's disease risk and dementia, followed by physical inactivity and low educational attainment. But as Mark said, actually, the prevalence of some of these risk factors actually have changed over time. As I mentioned in the beginning, about 10 years ago, the prevalence of obesity was about 13%, and it actually more than doubled now it's about 36%. And that means it actually has propelled midlife obesity to be one of the most important things that we have to think about when it comes to the prevention of Alzheimer's disease and dementia. Smoking, on the other hand, has declined a little bit from about 20% to now about 18%, which is good news, but it's still high. We need to keep doing, promoting smoking cessation programs as well, and encouraging people to maintain a healthy lifestyle, like maintaining a healthy weight.
And I think that underscores, the scope of the challenge that we all face. Susan, the fact that obesity, which is maybe the most recognized, identified, accepted risk factor of all, and has been known for decades, is worse now than it was before. And one reason for this, from my perspective, and with all due respect, is that many in your profession, certainly not you or your organization, are still prescribing medication before lifestyle modification. What's missing in our current medical education system, and how is that changing? Is it changing?
It is changing, Mark. And yes, and to Rock's point, there have been so many things lately that have really been emphasizing this. I mean, even the Institute of Health Metrics and Evaluation, the largest repository of health-related data in the world, in its 2019 Global Burden of Disease report, found that when looking at data from almost 200 countries, it's what people are and are not eating that's the leading cause of disease and death. And certainly it's what we are and are not eating and our lack of physical activity, and that are the leading drivers of obesity, to your point, Rock. And so all of these things are inextricably connected. It's not as though these chronic conditions are siloed. They're all connected. And yes, medical education is beginning to change, because there is this recognition that for far too long, we have really had an allopathic only approach to diagnose symptoms and to treat those symptoms with ever increasing quantities of pills and procedures, which is unsustainable. It's about disease management as opposed to health restoration and real prevention. And so, as I said, this is really, ACLM is championing the effort to fill the void of lifestyle medicine and medical education. And we have people like Congressman Jim McGovern and Congressman Burgess out of Texas, who recently pushed through a House resolution to advocate for nutrition to be incorporated into all medical education. And then we just participated, ACLM just participated last week. There was a monumental, historic White House conference on hunger, nutrition, and health. One had not taken place for 52 years. And ACLM made a huge commitment in support of that conference. And this was highlighted in a fact sheet that the White House issued last Wednesday. And our commitment was just one of a couple of dozen, and it was a $24.1 million commitment, 22 million of which was to offer 100,000 complimentary registrations for our 5.5-hour CME accredited lifestyle medicine and food as medicine essentials course. And so anyone even watching today who's a medical professional who would like to take advantage of that complimentary registration can go to lifestylemedicine.org/WH conference and take advantage of that, because we know that we have got to ignite a seismic shift in healthcare. We really have to. We want to be the catalyst that ignites this type of transformation that moves us from a system of just disease management to one that really is prevention focused, and even for many conditions to be able to treat those root causes in an effort to identify and eradicate the root cause with the goal of health restoration. And conventional medicine, we're grateful for it. All of the medical professionals that ACLM represents are conventional medicine docs. They prescribe medication. They just don't, as you say, Mark, they don't lead with it. They lead with a lifestyle medicine first approach. And this is what we are advocating, that lifestyle medicine become the foundation of all of health and all healthcare. We see these shifts happening, and even the White House conference last week is part of that shift that we are seeing and that we will all ultimately benefit from.
Speaking of healthcare champions, speaking of the White House, let me come back to Dr. Hacker. She's the champion. She hangs out at the White House. In fact, recently, the Biden administration, in part due to your support, Dr. Hacker, and your engagement, amended our nation's national plan to end Alzheimer's and added a new plank to that plan that's called Promote Healthy Aging, Reduce the Risk Factors for Dementia. What can you tell us about Goal 6 in the national plan to address Alzheimer's disease, and how is it now being used to actually address Alzheimer's disease at your organization, the CDC?
So this was a super exciting event, as you can imagine, for us in 2021, when they updated the national plan to address Alzheimer's disease, and they added that Goal 6, which emphasizes risk reduction. And those are much of what we're talking about right now. We led the development. We're excited to roll out our activities in support of the achievement. And in addition to this goal, it's aligned with our mission at the National Center for Chronic Disease Prevention and Health Promotion, which is really about promoting health and wellness for all. Well, this new goal builds on the CDC's National Healthy Brain Initiative, and that focuses on promoting dementias, including African American, Hispanic, American Indian, and Alaska Native populations, and those with intellectual and developmental disabilities. And through the initiative, we actually fund several organizations, including UsAgainstAlzheimer's, to address needs of the population at highest risks, in addition to developing culturally relevant materials. We also fund the Building Our Largest Dementia Infrastructure, or the BOLD for Alzheimer's Act. And that awards help to accelerate and elevate risk reduction at local, state, and national levels. And that includes BOLD Public Health Center and of Excellence on Dementia Risk Reduction, which in turn supports states, locals, and tribal public health agencies and help them identify and translate and disseminate all of this material. So basically, we work through a lot of our colleagues and a lot of our awardees to be able to get those messages out. The Center of Excellence, by the way, is going to hold its first national meeting on dementia risk reduction at CDC in May of 2023. And we're going to showcase the latest science related to the intersection of risk reduction and social determinants of health. We're also supporting a thematic network on risk reduction through 3 of the prevention research centers. And one of the strategies of Goal 6 is to address the inequities and risk factors for ADRD. And as I mentioned earlier, our work at the center focuses on addressing these social determinants of health that can lead to health inequalities. So along with Biden's executive order on advancing racial equity and support for underserved communities through the federal government, CDC is just one of the many federal partners working to meet the tenets of the national plan and reduce ADRD disparities among racial and ethnic minorities. There's a lot of evidence-based interventions that can promote healthy aging. They're often related to the risk factors we've been talking about. And that could make a substantial impact in promoting the health and well-being and independence of older adults. So a lot going on in this space. It was really just an incredible fire below our feet to be able to get this new addition to the national strategy. And again, we're working with all of our partners to make it a reality.
It is exciting. It's a major pivot from waiting on, hoping for the miracle cure, something that's going to cure it for us. And now the responsibility, folks, is coming right back onto our own shoulders. And Dr. Hacker mentioned health and well-being for all. She mentioned the social inequities, which is a great segue back to you, Dr. Nianogo. To be as effective as possible, this messaging has got to be slightly different for different communities because we all hear things differently. We all react to messaging differently. Your research has helped substantiate the fact that the modifiable risk factors for Alzheimer's disease and other dementias does vary. These factors do vary according to race and ethnicity. How so?
Yeah, thanks again. And then thanks again, Susan, for all your work in advocating again for a lot of research towards understanding the social determinants of health, especially as it relates to Alzheimer's disease and other dementia. The one thing that also it's important to also note is the opportunities that we have, especially as Mark was mentioning, the fact that different modifiable risk factors are important at a different level for different race and ethnic subpopulations. For example, midlife obesity, that is obesity in the midlife, actually was actually very important and one of the major risk factors for Black, whites, as well as American Indian and Alaska Natives. And I was mentioning in the beginning for Asian Americans, it was physical inactivity. For Hispanic population, it was low educational attainment. That was one of the most important things that we needed to tackle. And these actually are very important because, as Mark's mentioned, that means we can actually tailor and target and interventions for different subpopulations to be able to reduce the overall risks for that subpopulation and hopefully reduce the risk of Alzheimer's disease and really dementia overall. We think actually the differences that we actually observe right now is actually due to the relative difference in prevalence for different subpopulation. So for example, when we look at American Indian and Alaska Native, the proportion of smoking, for example, was about 3 to 4 times higher than that of Asians, and which actually translated into basically the proportion of excess Alzheimer's disease cases that we expect to see. So for example, if we take about 100 cases of Alzheimer's disease cases and other dementia, about 11 of them would be expected to be attributed to smoking for Alaska Native and American Indian, whereas about only 3 of them would be expected to be related to smoking for Asian Americans. So that actually gives us an opportunity to be able to target what is really most important for different subpopulations. And so I think there's hope there to be able to reduce disparities, tailor interventions through lifestyle changes, and hopefully reduce the overall burden of Alzheimer's disease and dementia risk.
So, Rock, where do we begin? I mean, your research has nailed it. I mean, you've proven that these risk factors are modifiable. You've proven that we have to have different messaging for different communities. But, but what's step one? What do we do? What actually can we begin to make a difference in our own lives?
Yeah, I'll start where I began. What is good for the heart is also good for the brain. So basically, as we've known for some time now, and as some of these, the study that we conducted, as well as other large randomized control trial, like the FINGER study, has been able to show pretty convincingly that engaging in a healthy lifestyle, such as exercising, eating healthy, and maintaining a healthy weight, was actually really, really important in actually reducing one's risk of Alzheimer's disease and other dementia. In our study in particular, maintaining a healthy weight was actually one of the most important things that one could do to prevent or reduce the risk of Alzheimer's disease dementia. And the other thing that I think is important also to note is it's really critical to focus on things like modifiable lifestyle risk factors, because those are mostly readily accessible to most people. Relative to pharmaceuticals, for example, if we think about it. And also, as we mentioned in the beginning, there's no effective cure for Alzheimer's disease. And being able, lifestyle changes, for example, is able to empower patients and individuals to be able to be proactive within their lifetime and act early whenever and if possible when they can.
Let me throw one out for the entire group, because I think Dr. Hacker mentioned that the administration's new goal and federal activities. What's the role of the private sector now? Is there an opportunity for employers? Is there an opportunity for technology platforms? Is there an opportunity for the wellness industry to get involved? I mean, how do we get the private sector to support what everybody else is saying that needs to be done? I'll just throw it out there.
Well, I'll hop in first with that. And Mark, this is, and I know that we would all agree, we face a crisis. I mean, we've just weathered and are still weathering the pandemic of COVID. We have a pandemic, a looming global pandemic that we're already living in of lifestyle-related chronic disease, with Alzheimer's being one of that. And Rock, as you just said, what's good for the heart is good for the brain, and is good for preventing type 2 diabetes and treating. And so these things are all inextricably connected. And we as a society, and this is what Karen so champions, is that we've all we need to come together on this. And the private sector has a huge role to play, because even when you look at healthcare costs in this country, a huge part of that healthcare cost burden is on the shoulders of our self-funded employer populations. And for them, there is immense profit in health, not only for the well-being of their employees, for reining in their employee healthcare costs, but from a productivity and in every other standpoint. And I think that there has been a lot of confusion around this. As I said before, I think that there is and evidence shows there's a really glaring lack of food, nutrition, lifestyle literacy in this country across the board. And so it is going to take major communications. It's really this intersection, as I keep referring to the Shirzais, because they're so deeply entrenched in this, and an important part of Us Against Alzheimer's and the Brain Health Academy. They really advocate for the intersection of technology, community, and media. And I could not agree more that we need to leverage these intersections and find out just really collectively come together and figure out how to optimize those, because it is about communicating to everyone that they are not a victim of their genes by and large, that we can, through the power of our lifestyle choices, even though many of us face obstacles, that we can be empowered to take far greater control of our health destinies by what we eat each and every day, how we move, how we sleep, how we think and manage our stress. And that is an empowering message for everyone. And it means that we can reverse this trajectory that is truly unsustainable.
And Dr. Go ahead. Go ahead.
I wanted to follow up on what Susan was just saying. I think it's really important, and thanks again for making that great point, that a lot of the lifestyle factors, now I think with a lot of research, we realize that all of these risk factors are common to a lot of chronic disease. Again, like heart disease, type 2 diabetes, Alzheimer's disease, cancer. So the good news there is that we can actually focus and target lifestyle factors and be able to prevent many chronic disease at the same time. So I think this is really empowering, but also I think it's important for patients to be able to know that there's something that they can do, and also something that they can do early. And I think making that message clear and simple and accessible to most people, and actually shifting the focus and the emphasis from pharmaceuticals to lifestyles, for example, could be really empowering and actually be able to help in the prevention of a lot of chronic disease, which is very disabling, and as well as it costs a lot to the healthcare system. And I think focusing on lifestyle factors, for example, is very, very important. And I think one thing that I wanted to mention as well is within the private sector, even like different schools, universities, workplaces, promoting healthy lifestyles, for example, like, walking within the office or outside the office, for example, are things that are simple, or even like having healthy diets, for example, at the cafeteria, are things that we can do to be able to change the culture within the institution.
Great point. Well stated. Dr. Hacker, I am not going to ask you to take on the lobbyists, the pharmaceutical industry, the fast food industry. You're welcome. But let's talk about the elephant in the room. There is a lot of money spent on major marketing messages that do not align with what we're talking about today. How big of an obstacle is this to the messaging that we're all trying to get out there?
It's a little bit like Samson and Goliath, right? I think that's the right comparison. Basically, we're dealing with a real challenge here because the resources that communities have, for example, to address some of these areas, if you look at some of these communities with food deserts, for example, they are fast food oases, if you know what I mean. So somehow they have a lot of options for unhealthy situations and not a lot of options for health. I think that some of that happens over time, and people will always argue, we want to give consumers what they want, right? So a lot of this is, I think, about how do we change what consumers want. To me, the fact that Alzheimer's is now evidenced and related to these risk styles is one more step in the process, right? So we knew that diabetes and heart disease and hypertension were related to these social lifestyle kinds of things. But now we know Alzheimer's is too. The challenge, I think, is both in the prevention elements, like how do we, it'll be fascinating to see what some of the Nutrition Summit recommendations are going to actually do. I don't know if you all saw recently, but the one about what does a healthy cereal actually look like? And I was a little surprised. I don't know about you, but when I saw the grams of added sugar in some of those cereals that I always took for granted to be healthy cereals, I got to tell you, it made me open my eyes. And this is my area of expertise, right? So I think some of this is going to be influenced by consumer knowledge, but I also have to say that, once an individual is quite obese, it is very challenging to change that simply by exercise and diet alone. And so I do think we have to match what we're doing in the lifestyle challenges with appropriate medical interventions. And to me, there's got to be a hand in glove kind of experience there. I am a little concerned that now, as we're starting to talk more and more about obesity medications and things like that, that people will simply turn to those as a response, which in some ways is much easier than trying to make these lifestyle changes. But I think what you've heard from all the speakers today is we've got to make those lifestyle changes for sustainability, for the future, really, of our population. So there's a lot to do, but again, we cannot do this alone, and we do need industry and we do need business to get on board and to help us, because it's not doing them any favors in the long run.
We are quickly running out of time. I want to get a quick takeaway from everybody. But before we get that, an audience member has asked that all speakers are emphasizing the importance of good eating habits, but there's not been recognition, at least during this conversation, about different dietary preferences. It seems that healthy diet takes an approach of one size fits all, and obviously that's not the case. Does anybody want to talk about dietary preferences and a healthy diet for different ethnicities?
Well, I'll just weigh in here. I mean, I think we've done, certainly at CDC, a lot of work in making sure that the types of recommendations are culturally appropriate. But there are still some things that all of us can agree to, which is too much salt, too much sugar, and too much fat. And regardless of what your preferences are, those are pretty much consistent across the range. And I think that when you're working in this area, it is absolutely important to work with communities to understand what those preferences are, to understand how, and to really get the advice from them about how they think they can begin to influence change.
And just to follow, on that, to say that actually we can actually agree on the main things that we could do: sugar, fat, as well as salt, but also like we can think about as ultra processed foods that basically do not require any cooking. They're ready-made foods and have been highly processed, have a lot of adjuvant in there and ingredients, and those are the ones that we need to avoid at all costs if we can. So just wanted to add to what Susan was saying. Go ahead, Karen.
I would agree. And Mark, and just to add to Karen and Rock's comments, it's always about keeping it simple. And as the Institute of Health Metrics and Evaluation, 2019 Global Burden of Disease report showed, it's about what people are and are not eating. And so to Karen and Rock's point, we're consuming an abundance of the packaged processed foods, too much added sugar and salt. And so what should we be eating? What has evidence shown to be those foods that are most protective of health and most fighting of disease? And it really boils down to something very simple. It's that which grows from the ground and as close to nature's package as possible. And it's whole food, plant predominant eating patterns. And because it's those foods that are plant-based, that are fiber-filled, nutrient-dense, antioxidant-rich, and those are the foods that evidence shows will really help us to protect our health and, again, fight disease.
I don't know if we could have more motivation than we do as a culture, folks. I think every survey that's been taken about the greatest fears of middle age and older adults reveals that cognitive decline is either at or near the top of the list. In fact, we fear Alzheimer's more than cancer. In most cases, we fear it more than death itself. So we do have the inspiration to change, the proof that we can delay, that we can diminish and even prevent the onset of Alzheimer's disease and related dementia. So guys, I'm going to act like a TV producer here and see how good you guys are at giving us a 60-second takeaway. What do we need to do? How do we activate the inspiration? Let me start with you, Dr. Hacker.
Well, I guess I would just say that prevention actually does work. We've kind of known that for a long time. And now the real challenge is, how do we embed it in our everyday lives in a way that's easily done by everyone, with accessibility for everyone. And I think the educational perspective on that, in terms of, even things like reading food labels, can get easier. And again, I'm going to harken back to the summit last week, because there were a lot of great recommendations, and I definitely advise folks to take a look at them.
Dr. Nianogo, give us your takeaway, sir.
There is something each and every one of us can do to reduce the risk of Alzheimer's disease and related dementias. The main one is maintaining a healthy weight through, for example, engaging in physical activity and eating a healthy diet. We can all do something to be able to empower ourselves, to be able to engage in some of these lifestyle modifications, to be able to prevent not just our risk of Alzheimer's disease, but also our risk of heart disease and type 2 diabetes.
Susan Benegas, the floor is yours.
Thank you, Mark. Well, I would say in my capacity representing the nation's medical professional association that probably more than any other is championing lifestyle medicine and food as medicine. It's a call to all of our medical professionals across this country to become trained and ideally even certified in the field of lifestyle medicine so that it is embedded into all healthcare in this country as a first treatment approach. So, because for every physician that we reach, he or she typically has a patient panel of 2,000 patients on average. So even the commitment that we made to last week's White House conference of the 100,000 complimentary registrations for the Lifestyle Medicine and Food as Medicine Essentials bundle, that alone, if we reach 100,000 physicians and they each have 2,000 patients, we will have planted seeds of change in 2/3 of our population. And so that's a call. And just for patients to know that we all can begin to take steps each and every day. It's never too early to start and it's never too late to start to really prevent Alzheimer's or, worst case, delay the onset. And so it's an empowering message that I think we've all brought forth today.
What an honor for me to hang out with you big brains and talk about keeping all of our brains healthy. My thanks to Dr. Karen Hacker, Dr. Rock Nianogo, and Susan Benegas for the work that you guys do every day on our behalf. You guys are on the front lines of one of the most important health battles in the history of humankind. And your message today is extraordinarily clear, folks. We can't just wait for that elusive cure. We have the power to save ourselves. That power resides in the lifestyle choices that each of us make every single day. So I ask you this, who is your primary care provider? You are. Thanks for joining us, and be sure to share this information with your family. Have a great day.
Thank you.
Thank you to Mark and our panel of experts. Up next, starting at 2:30 Eastern, our last town hall of the summit looks into the path to innovative Alzheimer's treatments in the next 10 years.
Alzheimer's is one of the world's cruelest diseases, robbing millions of people of their health and quality of life before ultimately taking it. Women and people of color are hit hardest. 2/3 of people with Alzheimer's are women. 40% of Alzheimer's patients in the U.S. will be Latino or Black by 2030. Tough problems demand innovative solutions. That's where Us Against Alzheimer's leads the pack, focusing on preventing the disease, detecting it early, and making sure everyone has access to treatments. On prevention, we built a national coalition to persuade the federal government to make Alzheimer's risk reduction a national priority. Our Brain Health Academy educates healthcare and wellness professionals in communities across the country. And our campaign, in coordination with the Centers for Disease Control and Prevention, reached more than 1 million Latinos and Black Americans in 2022 with culturally tailored information about Alzheimer's and brain health. Early detection and diagnosis are incredibly important, increasing the possibility of effective treatment while enabling people to make plans and spend time with their loved ones. Brain Guide has given more than 500,000 people the opportunity to complete a memory questionnaire and get resources tailored to their results. And we all want qualified patients to have access to safe and effective treatments. Us Against Alzheimer's is pushing for clinical trials to include more people of color, seeking accelerated federal review of treatments, and calling for Medicare to stop treating Alzheimer's differently than other fatal diseases. We're not in this alone. Our work is guided by the voices of patients and caregivers as we join on a shared cause alongside a broad coalition of scientists, policymakers, industry, and advocates. Together, we're bringing help and hope to the people who need it most. That's the power of us.
Hello, my name is Dr. Lakeland Eichenberger. On behalf of Home Instead, I would like to thank all of you for the work that you do to drive change in the Alzheimer's field. At Home Instead, we know firsthand that until there's a cure, there's care. We are committed to providing personalized care in the home to enhance the quality of life for those living with Alzheimer's disease and other dementias and their care partners. Our care is delivered by trained care professionals, and we recognize how important these care pros are in the care and support of people living with dementia and their families. Home Instead and our parent company, Honor, are on a relentless mission to elevate the caregiving profession, knowing that this will not only impact our amazing care pros, but those that they serve. The caregiving profession has historically been perceived as a career of last resort, but we know that care pros are essential. At Home Instead and Honor, we're putting a stake in the ground to transform the caregiving profession and elevate it as a career of choice. One of the things we've done is to work with the OECD and the Global Coalition on Aging around transforming the caregiving profession. This report that we're working on with them will be released next month. The first recommendation relates to changing the hearts and minds of society as it relates to care professionals. One of our champions for this external transformation is a care pro himself, Bill Glover. He's worked with us hand in hand to represent the voice of the care professional. Bill said it best, and I quote, "We help our clients with tasks of daily living, but that's a small portion of what we do. We develop a relationship with the client and their family, and we accompany them along their journey and lighten their load and make it easier," end quote. It's care pros like Bill and leaders like all of you who will help to ensure that the caregiving profession is a globally admired and desired career of the future. I hope you have a great rest of your day and enjoy the rest of the conference.
Access to capital and investment in innovation are needed to accelerate the development of Alzheimer's treatments. Our next panel will discuss impactful therapies that can be made possible when scientists, entrepreneurs, and leaders connect in the name of science. Welcome Russ Paulson, Chief Operating Officer of Us Against Alzheimer's.
Thanks for joining us for our last panel of the summit. Yesterday, our kickoff panel was about where are drugs today, what's coming in the pipeline right now, what's coming in the very near future. But as we've learned through the summit, all of us have a part to play. And one part of this ecosystem of getting to an end to Alzheimer's involves private funding. We heard a representative from the National Institute on Aging yesterday. We've heard from one government leader yesterday. We'll hear from another one after this panel. But there's private funding as well. And there's private funding at various stages, including early in the disease. So we want to talk about where science and private money intersect. With me today are people whose bios could take me the entire 45 minutes to read in thoroughness, but I'm going to give you the high points for each of them. Professor Dr. Philip Sheltons is managing partner of LSP Dementia Fund. He is a neurologist, professor of cognitive neurology, founder of the Alzheimer's Center Amsterdam at the University Medical Center Amsterdam. Philip is a leading global opinion leader in Alzheimer's. He's published, a lot of zeros out for this one, folks, over 1,100 publications in peer-reviewed journals. Dr. Laura Nissenbaum is Executive Director of Drug Development at the Alzheimer's Drug Discovery Foundation, ADDF. A neuroscientist by training, Laura has contributed to advancing more than 35 compounds through drug discovery and development, including taking molecules from preclinical discovery into clinical trials, taking them through clinical trials, and bringing 3 molecules to the FDA. She's also authored 35 publications in peer-reviewed scientific journals. And finally, my friend and colleague at ADDF, Mark Roithmeyer, the CEO, has helped increase their revenue threefold since he's been there. Previously, Chief Relationship Officer at the Leukemia and Lymphoma Society, previously President of Autism Speaks, and also national leadership positions at the March of Dimes. So this is about the intersection of money and drugs. And I think it's helpful to understand sort of how, when we were kids, we all learned about how a bill becomes a law. How does a target become a medicine for us? And the person who sort of worked across that the most, I think, is Laura. So we'll start with you, Laura. How does a target become a molecule, become a drug, become a medicine? What are the big steps, and who finds that?
Yeah, Russ, that's a really great question, and it's really difficult to learn about that. So, it's hard to believe, but our medicines take well over a decade to come from our initial idea and discovery up through the potential for being a medicine. So on average, a molecule can take from an initial discovery idea, 12 to 15 years, but well over that as well. And the number that needs to be prosecuted through that pipeline is really vast. From an initial idea, when we're trying to identify molecules, it takes well over 10,000 compounds or substances to make their way through the discovery and clinical development pipeline to be one that can possibly make it into a medicine. So from the discovery side, before we even make it into clinical testing, can be 5 to 7 to 10 years. And then just in the clinical development path, that can take 6 to 8 years itself. So this is something that really starts in academia, where we can try to understand what genes are important, what proteins are important. And so then from the ideas, that information can flow into smaller biotechs or into pharma. And there needs to be funding from governments to help with academics, but also then from private funding as well. And this takes us into our biotech companies who can begin to understand how molecules behave in animals and in humans. And then we need those big players to help get beyond the early stage clinical trials, so the phase 1, phase 2. And once there's some confidence in those molecules, they then need to go in very large clinical trials with hundreds to thousands of patients to be tested to see that the molecules are safe and efficacious. And this takes well over hundreds of millions of dollars for any compound to make it all the way into a medicine. It's estimated that it's well over $2 billion for that single medicine to make it to market. So we really do need to combine both the scientific expertise across the different ecosystems, as well as the financial wherewithal to bring those molecules all the way through those late stage clinical trials.
Thank you. That's daunting. So, Philip, you a couple of years ago left what for any of the early career folks on this call, early career researchers would look at as probably a dream job in academic medicine at Amsterdam. And you decided to be one of the people who tried to pick one of the 10,000, the 1 in 10,000 that Laura talked about.
Yeah.
So, and it's a big shift. Tell me why now? Why this shift and why now?
So the shift is indeed quite huge, but it's also logical. I mean, I've spent 30 years or even more of my academic life finding biomarkers to define the diseases in living persons. So when I started my career, the only diagnosis was after death or postmortem, and that is of course totally unsatisfactory and also not very useful for drug development. So I started my career working in biomarkers, trying to define the disease in vivo in order to make an accurate diagnosis about the brain pathology present in patients who present with a form of dementia. And I've done that for a long time, and I think we have been successful. The field has really sort of advanced in the sense that we are now making molecular diagnosis by using scans, by using blood tests even, or CSF tests, and that is the starting point for developing rational therapies. And so I thought, well, I can stay in academia and try to do my bit in drug development. I've did that all my life. I did drug trials, but to develop molecules and to help them getting from phase 1, phase 2, phase 3, as Laura indicated, that's actually what is needed is money. So I looked at the oncology field and where the progress has been made by venture capital, putting into the biotech, as Laura indicated, and making them progress until sort of a further stage, a next stage. And this was totally lacking in the field of Alzheimer's disease. And I think we cannot rely only on big pharma to develop drugs. Actually, they have, for a big part, left basic research or fundamental research in that part and just are scoping around the world looking for biotech. And we are there to help them. And we are there to look for the good companies that develop drugs in a proper way. And I thought it would be my task to put all my scientific knowledge and experience into that part. So indeed, 2 years ago, I gradually moved into this new role, and I'm really enjoying it. It's about science, but it's also combining science and money, and put your money where the science is and to do a good job.
So why now?
No, why now? I think the timing is right. In my career, it's now, but also the timing in the drug development is right. I mean, we used to say, we're saying that the neurodegenerative space or Alzheimer's disease and all the other dementias is now where oncology was 10, 15 years ago. So it's now actually the moment. We have the biomarkers, we have the right tools, we can actually pre-diagnose people already in the preclinical phase. That is exactly the moment that we have to start developing better drugs.
So flash forward 10 years from now, what does success look like for you in this new role?
Yeah, that's a very good question. Coincidentally, our fund also, usually most of the VC funds have a lifetime of 10 years, so that's actually appropriate. So within that 10 years, I hope to be the witness of at least a couple of the companies that we are have invested in, and we are monitoring them, and we have an active board seat, and there will be more to come, that a few of them will really have developed drugs and went from phase 1 to phase 2 or from phase 2 to phase 3, for instance, to be really saying, well, we did the job well, we chose the right candidates and we chose the right population to study it in, and see here, we can actually offer this to the pharma to develop it in larger phase 3 trials. As Laura indicated, those are the last part, the most important part, but also the most expensive part, and that's usually only done by pharma, but the whole path before that can be done by VC together with the biotech.
Thanks. So Mark, ADDF is a little bit like the fund that Philip is now leading, but it's a not just a classic private for-profit venture capital, it's venture philanthropy. Mm-hmm. What does that mean? And how does that enable you to, or does it enable you to take a different role in the ecosystem?
Yeah, completely. And first of all, Russ and everyone with Us Against Alzheimer's, thanks for having us here today, and terrific panel to be on. So, just very simply, venture philanthropy, instead of giving out grants to academic institutions or biotechs, we give out contracts. So if we're going to give $1 million to an academic institution to study a particular molecule, or $1 million to a biotech, it comes with a contract. And that contract says if that institution down the road sees any kind of deal flow, right, gets any kind of positive grip with that molecule whereby they are making money off of it, a percentage of that money comes back to ADDF. ADDF has to immediately put that back into the science. That's how we keep our 501c3 or nonprofit status. The niche that's been carved out here for ADDF, and particularly in neuroscience and particularly in Alzheimer's, it's quite critical. ADDF was founded by the Lauder family, as in Estee Lauder left a trust to her two sons, Leonard and Ronald, and said, do something about Alzheimer's. This was an important issue to their family. As you can imagine, folks like the Lauder family, they kind of scoured the earth for the best and brightest minds of what to do. So actually about 24 years ago, somebody at the NIA said to them, we're going to keep bringing a lot of money for the basic science of Alzheimer's, right? The brain is the last frontier. But even 24 years ago, they said, we're knowing enough about the brain now that somebody needs to start taking shots on goal. What that literally meant that somebody, instead of just, wow, this is an interesting insight in the lab, let's write a paper on it. We even move that interesting insight in the lab into the drug development process, preclinical, phase 1 safety, phase 2 target engagement, phase 3 pharma comes in and takes it across the finish line. So in this kind of unique way, ADDF had about a quarter century start on this. And I'll point out one or two seminal moments in that journey. One was about 10 years ago when pharma came into the amyloid theory, right? And pharma said, hey, there might be something to this. We'd like to take it across the finish line. So ADDF at that time stopped funding anything to do with amyloid because our view was we got it to where it needs to be, into the hands of pharma. But 10 years ago, the organization decided, and this was through Dr. Howard Fillett and the board, where is the light night shining? What else do we need to take a look at? And at that time, Howard did, it's a well-known phrase now, it's called the biology of aging. As we're all on this panel, we're all aging, we all age differently. Genetics has something to do with it, metabolism, inflammation, vascular, they all have different things to do with it. So there's about 7 or 8 pathways. And ADF started putting all their money into those 7 or 8 pathways, right? And funding what's called, and Philip knows this, Laura knows this, what industry calls the valley of death, where good ideas go to die because the academics get it so far, but pharma is way out here saying, we're not touching unless it's de-risked, right? And what ADDF is funds this risky, what's considered risky, innovative science. And we today are the largest, most diverse funder of clinical trials in the world. We don't put the most money in, as we heard, one drug could take $1 billion to $2 billion, but we're funding 35 different trials across this spectrum of biology of aging. Most are phase 2A studies that we're doing right now. So this is very unique niche. Where is the risk? How can we take that risk and innovation, de-risk it, and move it along so we can ultimately get to patients?
So, Phil, I was really struck with something that Laura said at the beginning. 1 in 10,000 compounds make it. And we know in Alzheimer's, I'm not even sure it's been 1 in 10,000. We've had so long since there was a victory in Alzheimer's. Your job is, I mean, you don't have the sort of the marching orders from the founders of a nonprofit like Mark has. Your job is to make money for the investors. How do you pick? How do you say, this is the one that I think is going to be the gold rush?
Yeah, that's a very good question that I can't answer, because it's a question of so just to give an example of how we work. So we see, I think, a new company every day sends us a deck and slides, and they have an idea and they have worked on it already. They have some animal work done, or even before that, or some later work. And then we just, well, we do two things. We look at the science behind it, and we look, is this a good target? Is the work that they have done, is this scientifically solid? Et cetera, et cetera. So is there indeed a niche for this, and is there indeed a sort of a part in the sort of where this drug could actually fill in? And then the second part is the team. I've come to learn also in this job that the team is as important as the science itself. So the people handling this company, the CEO, the CSO, the CFO, everybody involved is crucial. They have to be high quality, also experienced in that job. And so we weigh those things together. And it's a very difficult job, I can tell you, because we can only invest, I think, in 1% of the deals that we see. So we have to reject 99%. And we do this on the basis of also not good science, or not good team, or just not a perfect fit for our fund, because we can only we have a particular stage. Sort of, as you just heard, I mean, we're all in this sort of from an early, very, very early discovery. You need seed money. We don't do that. But if you have seed money and you brought the compound towards some animal experiments, and you want to think about the first in human study, that's exactly where we can come in. And there are also companies that come to us with phase 2B programs, but they're much too expensive. So there's a lot of things that come into the mix before we ultimately decide to fund a particular company.
So, Laura, I noticed in your bio, you've taken 3 compounds to the FDA. So you've had and I know your last job before you joined ADDF was with Biogen, a big company that's got a lot of investments in neuroscience, including an Alzheimer's drug. Take us into the mind of pharma as they look at these compounds, and they're trying to pick, and their bet is huge, as you and Philip have said, their bet is enormous. How do they decide that there's probably not at 10,000 anymore, that they're picking from concepts that have been sort of weeded down somewhere in the funnel, but they're still having to make choices? Can you take us into the mind of the pharmaceutical acquisition team to business development teams to figure out how do they make their choices?
Sure, that's a great question, Russ. And I'll loop back to something that Mark brought up, which is that valley of death. And oftentimes the reason that compounds don't make it out of that valley of death, and the pharma, what they're looking for are which molecules have been de-risked enough to provide evidence showing that they have the potential to reach the criteria that will be necessary to move something into those later stage trials. So some of the things that they look at are all of the things that we've been talking about. Is there target engagement? So does the compound that's being studied make it to the target where it's supposed to act? And does this have some type of pharmacodynamic, meaning is there some proof of mechanism that substance is doing what it's supposed to be doing? That doesn't necessarily mean clinical efficacy, because in early stage trials, there oftentimes is not sufficient number of subjects in these trials to be able to see a real clinically meaningful change. But there needs to be a connection between the mechanism of the drug in being studied and what should happen in the brain. So ideally, now that we do have some molecules that are beginning to show some clinical signals, so the data that was just shared by Eisai with lecanemab, that amyloid compound now has shown that there is some change in clinical signal. We can use that to try to understand the biomarkers that are correlated or associated with that change in clinical signal. So from a pharma perspective, ideally what you want to see is what's called a connected flow scheme in the discovery phase, meaning, your compound hits the target that you think it's supposed to hit. It shows some type of mechanistic change in the pathology of the disease. And then ideally, there would be some link, some reason to believe that that change in pathology would then cause a change in clinically meaningful outcome for the patients. So from a pharma perspective, that's the ideal. But we know that there are very few compounds early on that are going to have all of those boxes checked. So there needs to be some signal. And oftentimes, the way that you can get greater confidence is when multiple signals are moving in the right direction. So that might be multiple biomarkers. Have you identified the right population? Have you identified the right pathology? And can you show some movement in that pathology that there's reason to believe that there would be some meaningful change for the patients?
So Philip, back to you for a question following up. So the things that you and Laura just identified as like the hurdles to getting a medicine to patients are going to be common across all of the diseases that we've got in the world. But Alzheimer's has been really a tough nut to crack. We haven't had a drug in 20 years. We are, as you said earlier, 10 to 15 years behind cancer, maybe. Why is Alzheimer's so hard?
Well, it is indeed hard. I must also say, we haven't tried that long. Compared to cancer, our field is relatively very young, and the recent advances in all these biomarkers are still actually from this age. So since 2004, we have amyloid PET scan that usually changed the whole landscape. So that's relatively a short time ago. But I would say the brain is really very well equipped to protect itself against the drugs from the outside world, having the blood-brain barrier. So it's quite difficult, first of all, to make an accurate diagnosis in the brain itself. What kind of disease is there? Now we have the biomarker. And second is, how do we get a drug there that actually works in enough quantity, and can we measure the effect? So there's a lot of things that are much easier to do in the heart or the liver or any other organ than it is in the brain. And then on top of that, Alzheimer's is a multifactorial disease. Amyloid is very important, but also tau is important, and also other proteinopathies are important. Aging plays a role, vascular changes play a role. So there is not a single target that would give you the ultimate resolution of Alzheimer's disease. You have to probably target many of those. So we have just started. I would say lecanemab, aducanumab, these are the first signs that the approach that we are now taking to drug development is actually working. It's much better than we did before. Remember, the cholinesterase inhibitors were developed for patients that we really didn't have a clue what they had. We just made a clinical diagnosis, but half of them, they didn't have Alzheimer's disease probably. So we are really sort of changed the paradigm by using the biomarkers and going earlier in the disease. And that has to evolve in the next steps after the monoclonal antibodies into many, many other drugs focusing and targeting all the other aspects of Alzheimer's disease. But we'll get there.
I love to hear that. And I'm sure every patient who's tuning in wants to hear that. Mark, I'm wondering, Mark Wertheimer, if Philip made the move from a great job into another great job, making a big bet, and he says now is the right time, you managed to convince some very smart and very wealthy people to invest in Alzheimer's drug development right now. So they must think, and you must think, that this is the time but there must still be barriers, just given what all the scientific difficulties that Philip outlined and the recency of biomarkers. What do you see, Mark, as the barriers to additional financial investment from the private sector, and what can we do about that?
So a couple of things, and let me just go back and tag off on what Philip said, because I've heard so often Dr. Howard Phillip, who's a good friend of Philip's, and who co-founded the ADDF and is our chief science officer, he often says, Alzheimer's is right on time. And if you take a look at the history of just the last 30 or 40 years and how it was taught in medical schools, we're right on time. I think the issue that starts coming up is how can we make it go faster, right? And here I want to quote Michael Milken, who's had a lot to do with the cancer disease state, and he has spent some time looking at Alzheimer's, as have people like Bill Gates and Mackenzie Scott and Jeff Bezos, and who are all donors of ours. And Michael says it's not that there isn't enough money to do something about this, is that the money is not lined up in the right places. And Russ, I will say this for you and for our panelists and for the complete audience, the narrative is not right. For a whole host of reasons, the kind of mainstream media and the narrative gets caught up in, did Biogen's drug work? Did Eisai's drug work? And now we're going to hear about Roche's drug, and we're going to hear about Lilly's drug, right? And it's all on, the plaques and tangles, the scab that's made. And that is incredibly important. The fact that the scab can just be removed is incredibly important. The fact that the scab can be removed, and now we're showing some treatments like these last two drugs that seem to have some effect on cognition. How much for what person at the right time, still to be determined, right, to happen. But that's a part of it, because those of us who work in this field, and there really is almost like a silent majority in the scientific community, know the following: prevention, combined therapies, precision medicines. So when we hear Philip talk about, these two drugs that have come through that are taking away the scab, but you also hear him talk about these other pathways of aging, and how if somebody has an inflammation issue, it's going to be a combination. If somebody has a vascular issue, it's going to be a combination. And this is where, and I will let brighter minds than mine talk about, the importance of biomarkers comes in, and how you do that precision medicine comes in. So, Russ, I will tell you that the narrative is off. And what happens with this narrative is that the way our ecosystem is around all of this, we're almost forced to speak to this false narrative. What do I mean by that? These two drugs that one drug, Aduhelm, got approval, lecanemab, that looks very interesting, we hope is going to get approval. Two more that we think will look even more promising and hopefully get approved. UsAgainstAlzheimer's. Of course we want those drugs to be paid for. Of course, of course, of course. But it is still a piece of this. It's not the combined that will ultimately come and will take care of issues for big numbers of people who now all of a sudden can remember their grandchildren's name, who now all of a sudden are going to pass from something else but not being Alzheimer's. And so getting that story right is part of an issue. I know, Russ, I've talked with you about this, and I'll talk with others, with everyone here. ADDF now going forward, we're going to start working more aggressively with what we call the neuro-curious VCs that are out there, to explain to them where this is, to hopefully bring their money in sooner. We're going to look for strategic partnerships with the big pharmas. They view this biology of aging as a complementary strategy, right? Of course, they're myopically focused on their one molecule, as of course they would be. But it's not that they don't have an interest in this. And how do we bring pharma closer to this, right? That will do. The other thing, Russ, that I will say, and it's only because it's us against Alzheimer's and you all are brilliant. There was a reason in the 60s, 70s, the war on cancer happened. And the reason was is things were lining up that they thought, okay, this is the time now to take big, big pots of money and pointed at exact things, right? There's no question this is what's happening. There's no question over the last 3 years we've moved to that. The next 3 to 5 years are only going to move us there even faster. But it's not just Biogen's money. It's not just Lilly's money, right? It's not just Philips' money. It's not just the DDF's money. It needs to be better coordinated, better targeted, right?
Sort of the false narrative. It's also the negativism that has been going around for many, many years. Nothing can work in Alzheimer's. It's a graveyard. And people start to believe this, and scientists start to believe this. And this is, look, that's why this lecanemab is so important. It has to change the story. So it will attract more money. We need more money. There is still a fraction of the money in put in Alzheimer's disease research than there is in cancer. So more money, but also more smart people that see a career in neuroscience doing research at the proper places. So it's a combination of those. And then the people outside, they said, well, yes, it can be done. And yes, we have to believe it, that it is possible to create drugs for all these diseases. And that's why it's so important to emphasize that we have taken the curve here, and that ADDF and DDF and all the people that Mark mentioned are crucial, in combination with all the governments, to put more money into research and get more money to work in research, because we have to take the opportunity that we have a start now, but we have to work on all these complex sort of other mechanisms that Mark mentioned. And there are people out there. And so the companies that we see, hardly any of them works on amyloid purely. They do on the inflammation pathway, lysosomal storage issues, mitochondria, gene therapies. There's a lot out there, and it all needs to be developed, of course.
I want to follow up on that in just a second, but I do want to let folks know, if you're watching live, below where you're seeing us, there's a place where you can fill in a question for this expert panel. And if you have a question, fill that in, and I will get to as many as I can in just a minute. I wanted to follow up on that last sort of conversation. Since I've been in this field, it felt like when I joined Us Against Alzheimer's in 2019, there was a lot of depression. There's a lot of negative reports on drug development. And we've kind of been on this sort of roller coastery thing. But it also feels, even among the scientists that I spend time with at conferences, there was this hope, maybe even expectation, that we're going to have penicillin for Alzheimer's, or that we're going to have some kind of silver bullet. Philip, I'm wondering, you've spent your whole career in this in various aspects. Do you see a silver bullet?
No. I think if we follow on of what Mark and I had said, I mean, there can't be a one silver bullet. I mean, there has to be several bullets actually at the same time, the combination therapy. And also one bullet may work for one person, but it may not work for the other one. So that's where the precision medicine comes in, and targeted drugs for targeted sort of proteinopathies or targeted issues in the brain, I would say, just as we do as in oncology. It's not that different, actually. So when I grew up and you had lung cancer and there's only one therapy, you gave chemotherapy to everybody or radiation therapy. Now we know that in this specific lung cancer, you have 35 different species and they're all treated differently. That will happen with the brain as well. We will get to know, using all the biomarkers, all the different elements in the brain that are sort of not working well, and we have to target medicines for each of them. And that will happen.
Great. So a couple of you have talked about biomarkers, and I wanted to ask about that, because it seems like that is a big game changer in our field, to have blood biomarkers. It was a big change to have PET scans, right? So you can no longer have to diagnose the disease definitively on autopsy. You can diagnose it definitively with scans. They're hard to get. I mean, in the US, there are whole states where you have no option to get a PET scan, and they're where you think difficult. But I wanted to ask about how you see the advent of blood-based and other sort of more easily determined biomarkers, not just on the sort of science, but also on, does that affect finances? Does it affect people's willingness or ability? Does it shorten trials to the point where they're less expensive? What's the impact of biomarkers on the financial ecosystem?
So if I may try to answer this one, I think yes. So the biomarkers have been crucial for, first of all, for diagnostic purposes, but also to understand the disease processes, to follow them, to monitor them, to make prognostic assumptions, and to find out the target engagement of the drug. So the two drugs that were mentioned have a massive and enormous effect on lowering amyloid, and you can see this on the amyloid PET scan. So the biomarkers have a definite role to play. The question that they are not available ready yet for clinical utility is also because there has been no therapy. So it's a catch-22. So once the therapies will be out there, there will be the need to have MRI facilities, PET facilities, CSF laboratories. There will be needing more doctors, more clinics actually working in this field. Otherwise, we can't handle all the patients. So that will sort of ultimately work out as well. And the blood-based biomarkers, I think, are the biggest revolution of the last 3-4 years, actually, and they will enable to stratify patients earlier on, to detect patients earlier on, to prevent patients undergoing expensive tests like PET. If you don't have the disease, you can actually skip that one. So the blood-based biomarkers can be used for sort of triage or sort of screening procedure at the first instance, and then you can select only those who have a positive biomarker, for instance, in blood. So that's why I see they actually can help reducing the cost of clinical trials and reducing the length of the inclusion period.
Yeah, and Russ, I can add into that. The blood-based biomarkers have already had a huge impact on some of the clinical trials. So there's ability to, at a minimum, use them as a screening option to reduce the number of patients flowing into the amyloid PET scans. So that is, we don't want that to be the primary reason that patients fail their screening for clinical trials. So there have been a number of trials that have already started to implement that. And there's also then hope as these blood-based biomarkers are being utilized more in additional populations, so that there can be an ability to understand how they behave in not the standard clinical trial patient, but in more and diverse populations. And on the flip side, I would say that it's not just blood biomarkers that we're excited about. There's the optical, so the retinal scans that are being developed, the digital apps. All of these are investments that ADDF has made with our partners through the Diagnostic Accelerator. We expect that these also will be coming to fruition over a number of years, where they can help not only with clinical trials, but also in screening patients in the real world to get them to their doctors to have that really important conversation that can then lead them to the ability to try some of these new medications that will be coming to the market.
Laura, do they help? I'm going to go back to your 1 in 10,000. Does the advent of more easily obtained biomarkers help with that selection? Does that make it easier? Talk about how that is, if it does.
Yes, in a number of ways. For those that have been in the field for years, we know that the first clinical trials for Alzheimer's disease, as Bill mentioned, were run in clinically diagnosed patients. So for some of the first anti-amyloid therapies, more than a third of the patients were included who did not actually have amyloid. So if you don't have amyloid in the brain, why would you treat with an anti-amyloid therapy? So at the first and foremost, getting the right patient into our clinical trials will reduce the cost and speed the development of the drugs. And then we know that there are not only amyloid and tau pathologies, but the other pathologies that we're talking about, whether it's neuroinflammation. So ADDF is helping to fund a number of very innovative researchers who are looking to try to identify biomarkers associated with neuroinflammation in the brain. So all of these will, again, help us to be able to study and develop these precision medicines. So we need precision clinical trials to be able to assess whether these more novel and biology of aging targets can be effective.
Quickly, just one last little follow-up on the biomarkers question. Philip, you've spent so much of your career on biomarkers. I hesitate to let you off without asking one more. So you and Laura both talked about sort of biomarkers as a screener, as trying to make sure we've got the right population. They might shorten clinical trials by making sure that we're not wasting time in the recruitment of people who aren't actually there. But they're not at a point where we can do an Alzheimer's trial in 6 months because we can see a biomarker moving and know that that's going to make a difference in clinical outcomes for patients. But we can do that with other diseases. Are we getting close?
Oh, I disagree. We can do that. Oh, we can do that. Especially in phase 2, biomarkers are already used to look at target engagement and hints of efficacy. And if there are none, if the blood-based biomarker or the PET amyloid imaging, tau imaging doesn't move or move the other right direction, you can actually stop the development of the drug. So it's really helpful to kill the darlings that were otherwise wouldn't have been killed and would have taken a longer time to prove them unuseful in phase 3. So yes, I think we will get there, as in the MS field, for instance, also, that we first of all look at the biomarker as a signal of efficacy or not. And we can use that as a proxy, as a surrogate marker for efficacy. That was actually, for me, also the vision that the FDA had in approving aducanumab. Whatever you think of it, they had a vision that a move in the biomarker is actually predictive of a clinical effect later on. And that's actually very, very sort of exactly to the point. And I think we can do this with more sensitive biomarkers earlier on. So p-tau is a good example. There are some companies there that are testing drugs at the moment where you see already a shift in p-tau in 6 months. So, and if that is sort of proves also to be a clinically useful drug, then we are there.
Fantastic. Let me ask the panel real quickly about the ultimate, I guess, silver bullet isn't really penicillin for Alzheimer's, it's a vaccine for Alzheimer's. What needs to happen to get us there? How optimistic are you that we're there if we get back together in 10 years? I'll start with Laura.
Yeah. So I think I would reframe that to think about vaccines. So we know that it's not a single pathology that is really underlying Alzheimer's. And I think that we need to look at this disease as we've talked about, it's the biology of aging. So there are multiple antecedents, so multiple causes, multiple pathologies associated with Alzheimer's disease. So I do have hope that there will be huge strides towards both the understanding and the development of drugs and bringing those drugs to market. So that's where I would put our hope.
So Philip, what do you think in your 10-year horizon for your fund? Is there a vaccine for some form of Alzheimer's?
I think so, yes. So basically what has been developed now is passive immunization, so monoclonal antibodies that you have to inject. But the other side of that is actually active immunization with a vaccine. And companies are working on tau and also working on amyloid vaccines. So yes, I think that's actually a very clever way to do that. We had so the very first vaccine that was developed had a lot of side effects, but it was actually the wrong vaccine. It had a massive sort of immune reaction, but we know now how that came about. So I think the next sort of generation of vaccines will be cleverly developed. And I also would pitch in for gene therapy. We're getting there as well. Probably not for Alzheimer's disease to start with, but for the more rare forms of genetic FTD, for instance, gene therapy may be an option. And in 10 years' time, we will see some of those therapies come to life. Yes.
So my last question actually relates to what you were just saying, Philip. But let's say that we're getting back together again in 5 years, which would be fantastic to have the same panel together in 5 years. Where do you think, what will be the big advances? I think Philip, you just named one or two, but in 5 years, what are the big advances, and what will that mean for investment in the field? I'll start with you, Philip, and then Laura, and then close it out with Mark.
So I think so. The investments in the field are already picking up because of the successes that we just mentioned, and I think it will grow. People will come to understand that neurology and neuroscience is the next big thing after oncology. So we have to invest in it, otherwise we have no future anymore. So I think that's in 5 years' time we'll see how that has played out. But I also think that in 5 years' time we'll have of the drugs that are now being developed in the late stage, we'll have ways of administration like an oral formula or a subcutaneous formula, so easier ways and less burdensome and also less costly for the patient and for the society, sort of building on the themes that we are now discussing.
Thanks, Laura.
And what I would add to that is, we will see the anti-amyloid therapies available. As Philip mentioned, I think some of these will begin to be available with more easily accessible formulations, subcutaneous, et cetera. But on top of that, what we're going to start to see are the combination therapies. So adding on, use it to some of these other aspects of the biology of aging, bringing these forward and close to market so that we can look for greater efficacy. It will be able to slow the progression because we'll be coming at it from multiple angles. So this will really be where we're headed. And then ultimately using those biomarkers to identify which of the therapies that should be used for the individual patient.
Mark, bring us home.
I not leaving a lot of breathing room on those. They're well answered. Almost in reverse order to what Laura just said. First of all, more and better biomarkers. And if you want to know, you're going to be able to much more easily find out. It could be going for an eye scan to your ophthalmologist, right? And that, Russ, if you think about it, that's mind blowing in and of itself, because that brings up all sorts of things, right? But more and better biomarkers, better amyloid results. And we're going to be seeing our first diverse targets starting to green shoot through the ground of, oh, there's promise on inflammation. Oh, there's promise on vascular that's going on. And Russ, I'm so happy that the two doctors spoke to this first, because they said the same thing. This is not like crazy thinking. This is like, it's right in front of us right now. And really the pressure's on folks like Philip and folks like ADDF and folks like DDDF. How fast can we move this? But we need partners in this narrative, even what the real narrative is, because Milken wasn't wrong. Money can speed science. There's a lot of money out there. But if you think about those billions that are going into very singular things, if some of that was coming into these diverse targets, the whole field would move faster.
Thank you all. Thank you to the panel. 3 visionaries and brilliant folks and thinking about what's it going to take for all of us to get a combination of therapies to treat what is no doubt a proliferation of subtypes of Alzheimer's disease. Up next, Senator Susan Collins, interviewing with George Vradenburg. Senator Collins, one of the early visionaries in the political leadership to bring funding for Alzheimer's to where it is today. Thanks for joining us.
Thank you to Russ and our panel for a very informative conversation. Stay tuned for a fireside chat with Senator Susan Collins of Maine and Us Against Alzheimer's Chairman George Vradenburg in just a few moments.
Joining me now is one of the most respected members of the United States Senate, Susan Collins of Maine. Senator Collins, the Alzheimer's community is so fortunate to have you in our corner. I particularly appreciate how closely you work with our organization, Us Against Alzheimer's. Senator Collins has earned a national reputation as an effective legislator who works across party lines to get things done. For the past 8 consecutive years, she has been ranked as one of the most bipartisan members of the United States Senate. She serves as a senior member of the powerful Appropriations Committee. She's a member of the Aging Committee, the Health, Education, Labor, and Pensions Committee, and the Intelligence Committee. She's a busy lady. She founded the Senate Diabetes Caucus and has led the effort to more than triple federal funding for diabetes research. Thank you for that. She's championed the efforts to lower the cost of prescription drugs. As the founder and co-chair of the Congressional Task Force on Alzheimer's disease, she has worked to increase funding for Alzheimer's research and to strengthen support for family caregivers. In 2011, Senator Collins authored landmark legislation creating NAPA, the National Alzheimer's Project Act. So we will ask you questions about that and about your other activities on behalf of the Alzheimer's community. So I thank you for being here with us today. Senator, you are the senior ranking member now of the Appropriations Committee, and who knows what's going to happen in the midterms. So you can be chairman or the ranking member of the Appropriations Committee. You're on the Health Committee. You're on the Aging Committee. So you are a leader in all things healthcare. And so I'm curious as to how you see the next 3 months and then the next couple of years in terms of health priorities. What are your priorities for that period of time?
Alzheimer's research will continue to be very high on my priority list. Healthcare in general is of great interest to me, and as a senator representing the state with the oldest population in the country, I'm particularly focused on diseases like Alzheimer's and diabetes that affect older Americans. So I'm really proud of the work that we've been able to do in increasing funding for essential biomedical research. The progress that we have made, thanks to the advocacy of Us Against Alzheimer's and other groups, has just been extraordinary. When I first founded the Alzheimer's Task Force in the Senate, there was very little focus on Alzheimer's disease and dementia in general. In fact, people were still unclear that dementia was a disease. Think about when we were growing up, you would hear people described as being senile, as if it were an inevitable part of aging. So I think we've come a long ways towards those days, and toward achieving our goals. My hope is that the end of this year, when we finally do the omnibus appropriations bill, that we will see as much as $3.5 billion for Alzheimer's and other dementia research. That would be a record high and a long ways from where we were many years ago.
You know, when I started my organization, you spoke at the launch with Sandra Day O'Connor.
Yes.
Which is tragic because she's died of the very disease that she was advocating on behalf of her husband at the time. It was, just as you say, virtually standstill in terms of any government efforts or focus on this disease. So thank you for that. But one of the things that's driven this has been the National Alzheimer's Project Act, or nicknamed NAPA. That was your brainchild back in 2011. So what did you hope to accomplish, and have we achieved what you hoped we would achieve with NAPA?
NAPA was the first major legislation, a bipartisan bill that I introduced with Senator Evan Bayh that focused on Alzheimer's, set up an expert council to help us figure out how much we needed to invest in the disease, and set a goal of achieving a means of prevention or effective treatments or even a cure by 2025. That was an ambitious goal, but it was important to have that kind of goal. The result of that legislation was that the expert panel recommended that we should be investing $2 billion a year. Now, back then in 2011, I think the amount that was being allocated for Alzheimer's and related dementia.
400 million.
That's what I was going to say. You know the exact figure. So think what a stretch it was to have this panel of experts say 400 million isn't nearly enough to make progress. You should be investing $2 billion. We needed that kind of expert advice to make the case. Advocates needed it, we needed it in Congress. So I see NAPA as being a real breakthrough in focusing the country's attention, the biomedical research community's attention, the advocacy groups' attention, and most of all, the attention of members of Congress on the need to greatly ramp up funding.
You know, back in those days, it was taken as a given that Congress would never allocate more money to one disease over another disease. And NAPA changed and broke that paradigm to actually allow us to focus on the diseases of greatest suffering, the greatest cost, the greatest impact on American society. So thank you for doing that. It really is, as you say, quite a breakthrough in how we approach this disease. And we kept going. So you now are looking to reauthorize NAPA, because it was authorized only through 2025. What do you hope to achieve with a reauthorization, and are we resetting our goals?
I want to keep the momentum going. That is so important. And the funding is so critical. You're absolutely right that it can be a battle to single out specific diseases for increased funding. We've done it with cancer, and it's led to breakthroughs. And if you look at Alzheimer's disease, it is our nation's most costly disease. Mm-hmm. If you look at the trajectory as our nation is living longer and more people are having to battle this devastating disease, it is evident that we must continue the trajectory of increased funding, and also looking at other factors and directing the research in other ways, such as the lifestyle factors that you've worked very hard on. But the amount of money that our country is projected to spend on Alzheimer's and related dementias is $1 trillion in the year 2050. So that should be a clarion call to reauthorizing NAPA, to strengthening it, and to continuing the journey that we're on. I would also say it's not just the financial cost, it is the human cost. Those of us who have lost loved ones to this devastating disease, I lost my father, my grandfather, 2 uncles, I know full well the toll that it takes. And caregivers, those heroic spouses, those home health aides, other family members who have stepped in, particularly in this time of shortage of home health aides, it's really difficult for them as well, and takes a toll on the health of spouses who are often confronting health problems of their own. So it's really important that we look at how we can support caregivers too.
So it is, you're absolutely right. It is a family disease. It is not an individual's disease. And the cost to caregivers out of pocket, as well as cost to the federal government, and the pain and suffering of multiple generations. A substantial number and percentage of caregivers are now teenagers, are now young people, or are grandchildren, and they're taking care of their grandparents. It is a remarkable impact. I lost 3 generations of my family to this disease, and that's why I've committed the rest of my life to it. So you're absolutely right to focus on the family as well as the individual with the disease and the cost to the nation. So I'm curious, so you talk about modernizing the NAPA. So I'm curious about what you mean by modernizing as well as just reauthorizing.
Well, we've learned from the research, we've learned that there are some tantalizing other areas to pursue, and one is that there may be lifestyle changes that can be made that would help slow the onset or the progression of the disease. Think if we could just delay the onset by 5 years, what a difference that would make to the quality of life of so many people, whether they have early onset Alzheimer's or whether it's a later stage in life. It would make such a difference. So we need to look at those issues. We also need to look at other very tantalizing research aspects. For example, many of the clinical trials have focused on the buildup of amyloid plaque in the brain. But now there's some evidence that inflammation may play a role, that the tau protein may play a role. It's very hard with this disease to figure out what is the consequence and what is the cause. And I suspect that ultimately we're going to learn that there are multiple factors that are involved. We also know that vascular diseases can lead to the onset of dementia. So there are all these tantalizing research leads that are being pursued, but we need to elevate and expedite that research.
One of the things that I had hoped when I joined the NAPA Council at the outset was that this would become a national plan, not just a federal plan. I'm curious as to whether you think that we're doing enough to integrate the government efforts and private sector efforts in order to achieve the goals of NAPA as we move forward.
That's a great question. There is exciting research, not always federally funded, sometimes funded by pharmaceutical companies, sometimes occurring in university settings, that is going on all around this country. I've visited, for example, the researchers at Harvard, at Jackson Laboratories in my great state of Maine, at the University of Pennsylvania, at the Mayo Clinic. There are a lot of research centers, and we do need to make sure there's support, there's coordination, there's federal funding, but also we need more sharing of information, of the results, and sometimes that occurs. It occurs when there's federal funding, sometimes it doesn't. That's why, for example, I would say that the effort needs to not just be national, it needs to be international, because there is exciting research that's occurring overseas as well. And that's why these summits have been so important.
You know, 2/3 to 3/4 of the cases of Alzheimer's are in low and middle income countries. We think we have a large baby boomer class of 76 million people. China has a baby boomer class of 460 million people. India has a baby boomer class that's larger. So you're absolutely right that there are brilliant people around the world. There's research going on around the world, and there's very little international commitment to this. So focusing as you have on international and global efforts to bring together both resource and brains around the world is so central. So I congratulate you for thinking that way, because very few members of Congress think that way. So thank you for doing that. You know, one of the things that you did during the course of the last several years is create a professional judgment budget. This was basically asking NIH every year to tell you how much additional funding they needed in a following fiscal year in order to try to achieve the 2025 goal. That has worked, I think, brilliantly in creating a real conversation between the executive branch and the congressional branch in terms of sharing this goal. Do you think that a professional judgment budget ought to continue as we go to 2035?
I definitely do. Right now, what would happen otherwise, as you well know, George, is the budget from NIH goes through OMB, and OMB is looking at numbers. It's not necessarily, with all due respect to OMB, but its job is the budget, numbers. It's not really focused on policy, nor is it really focused on long-term savings, which if we conquer this disease are going to be enormous to the federal budget, to both Medicare and Medicaid. So it's really important that NIH be freed from the constraints of OMB and able to communicate directly to Congress on what the needs are. I think that is absolutely critical. You know, every year, Francis Collins would come before the Senate Health, Education, Labor, and Pensions Committee, on which I serve, and he always knew that I was going to ask him this question: how many worthy grant applications are you receiving for Alzheimer's disease that you cannot fund? So after I asked him the first couple of times, he came prepared with a chart showing me how many there were and how many they could fund. And I'm talking about worthy applications, one that would advance our understanding of the disease. And there was always a gap. But if you work, and I think the world of Dr. Collins, I call him my cousin, even though we're not related, and he's made a real difference in helping to advance the research. But you're absolutely right, that professional judgment budget is essential to guiding us.
As you think through the inclusion of risk reduction factors in our national plan and look at the professional judgment budget, which is NIH-centric, how do we get to a place where we begin to take account of the cost savings and the cost investments we should be making in risk reduction interventions that could delay or prevent a significant percentage of the cases of Alzheimer's?
It is really interesting to see the studies that have focused on vascular diseases, heart disease, for example, and the general health of the individual, how they eat. My mother always swore that the Mediterranean diet that she adopted delayed my father's onset of Alzheimer's, which ran so heavily in his family, till he was in his mid-80s. And I, you know, she may be on to something based on what we're seeing. Exactly. And exercise, all of those may be factors. So I think it's important that we pursue that avenue aggressively, because if there are steps that each of us can take right now that would help delay the onset, we need to know about that. We need to have it further explored and backed, but we need to know about it. So that's why I think it's so important. And thank you for all your work in making sure that that became part of our goals.
Well, one of our objectives now at Us Against Alzheimer's is to think through how we can bring the private sector to that conversation. Because if anyone knows my behaviors, it's probably Facebook or Twitter or somebody out there in social media land. And if we can enlist employers who have a deep interest in healthy aging because of the pension plans they have, because of the health of their workforce, if we can enlist the technology industry, if we can enlist the lifestyle industry in trying to align themselves with that goal and create a national effort, a whole of society effort around healthy aging, this society will not only benefit all of those who are aging, which is better than the alternative, as they say, but it also is going to, as you say, reduce the cost to society. So I think, I noticed that you put OMB on the Napa Council this time around. I'm curious as to whether that was a hint that maybe we ought to be thinking a little more broadly.
It is indeed. I hope that if OMB gets more exposed to the research, the amount of money that is needed, and the potential cost savings, that it will change the natural friction that occurs between OMB and virtually every other federal agency. This is not unique to NIH. And I think it would be good for OMB to be exposed to what the research can mean in lowering Medicare costs, Medicaid costs. It's not going to lower it, but it'll prevent this explosion in Medicare and Medicaid costs.
Well, I congratulate you for your thinking on that score. As we know, research is essential to progress here, and you've done so much with the NAPA effort and the funding effort. But we also need eventually to get drugs to people. So I'm going to ask you about the next step. There are two of them. One is regulatory, where we saw the FDA now using accelerated approval mechanisms to approve a drug for some large-scale fatal disease that has a real substantial evidence base for having effectiveness. The other is Medicare, who has to cover these drugs in order for their actually people to get them. I'm curious about what you think about the accelerated approval mechanism. Is it useful? Should we be continuing to use it? And then I'm going to ask you about Medicare.
I support the accelerated approval process. It has allowed hundreds of valuable pharmaceuticals to reach the market far earlier than they otherwise would for diseases that have been really challenging for our country. And the FDA still has a very rigorous review process, so I don't want people to get the impression that somehow safety is being compromised. It is not. Senator Tim Kaine and I have introduced a bipartisan bill to help strengthen the accelerated approval process by putting more transparency into it so that there'll be better understanding of FDA's decision. But I have a lot of confidence in FDA, and I think I can anticipate what your next question is going to be, but I'll wait till you ask it about CMS.
Thank you. Well, as you know, we did get an FDA-approved drug last June of 2021. FDA found it to be safe and effective and approved it under the accelerated approval process. Medicare disagreed and refused to cover it, and now that drug has been withdrawn from the market. I'm curious what you think about the Medicare decision not to cover an FDA-approved drug found to be safe and effective.
I completely disagree with CMS on its decision. And I cannot recall another time when the FDA has certified and approved a drug and CMS has refused to cover it.
It's unprecedented, so your memory is good. There is no
That's
such
good.
case.
I think this is outrageous, and it is not CMS's job. CMS got way outside of its lane. It is not CMS's job to deny the use under the Medicare program of an FDA-approved drug, particularly citing safety reasons. Now, I think the real reason was cost and not safety, but CMS claimed safety reasons. Since when does CMS make decisions on whether a drug is safe? That's the FDA's job. Now, if FDA ignored safety data, that would be of great concern to me. But CMS has not been able to point to data that indicates that. I wrote to the administrator of CMS to express my strong disagreement with its decision. And here's what really bothers me. I think this chills the development of other drugs in the same class, because the manufacturers are going to be hesitant about proceeding with research, which is very expensive, and clinical trials, and going through the FDA's process, if there's no guarantee that CMS is going to approve it.
Well, Senator, you have been terrific. You know science, you know finance, you know the government's budget, you know regulatory issues, and you know coverage issues. So you have demonstrated an extraordinary range of knowledge about the Alzheimer's and related dementia fields and healthy aging and how it relates to Alzheimer's. So I want to thank you for your efforts. I want to thank you for the clear study and attention you've paid to those of us out in the world who have experienced Alzheimer's in our family, as you have, as I have, and the millions and millions of people who have. So thank you for your attention, your focus, and your leadership on this.
Well, thank you, George, and let me turn around the compliment and thank you. Your advocacy has been tremendous in supporting the work that we're doing on Capitol Hill. We could not do it without your work and without advocacy groups standing there with us making the case. And I'm very grateful to you for your commitment. And believe me, this is a passion for me. Thank you.
Thank you, Senator.
So how do you summarize all that content? That's what they've asked me to do. I'm going to do a poor job of it, but I want to do a little tiny bit of sort of reflecting back on what we've heard in the last couple of days of the Us Against Alzheimer's National Alzheimer's Summit 2022 version. So I said this when I was wrapping up yesterday, and I still believe it. Our world is changing in Alzheimer's, changing for the better. All kinds of reasons to believe that. Now, we kicked off yesterday with George sort of summarizing some of the changes that he's seeing, and also reminding us of the things that need to continue to change. And today we kicked off with Ken Dychtwald with a very big picture view of why we need this change and sort of a macro level view of all that's left to do. And if you didn't get a chance to hear George or Ken, I'd recommend that you look at the tapes that will be available tomorrow of those sessions. It's going to take all of us, that's the us and Us Against Alzheimer's, to make all of these changes that need to happen. And you've heard from us, you've heard from patients and caregivers, Jim and Jerry Taylor specifically yesterday, and several of us who've been caregivers. You've heard from politicians. We just got done with Senator Collins. And their work, the pioneering work that Senator Collins did in increasing funding to help understand the basics of this disease. And then yesterday, Congresswoman Eshoo and the breakthrough work that she's done to put together a new agency, which is not a trivial undertaking in Congress these days to pass any legislation, let alone something that authorizes a whole new agency, which is going to focus on translating good ideas into actual solutions for us. And Alzheimer's will be a focus of that. Politicians are critical to the success, but they're not sufficient. And you heard Senator Collins say that it's going to take us. She said they couldn't have done it without patients and patient advocacy. It takes scientists, it takes clinicians. If you heard the panel just a little bit ago, it takes investors, and it takes you, and it takes me. And we heard a theme throughout this around equity. We heard yesterday about clinical trials, and we heard today in prevention about the importance and the really lasting impact of social determinants of health, things that need to change fundamentally to change health outcomes for all of us. And even the differential effect of various risk factors on people in different subpopulations. We can't have a one-size-fits-all approach to the change that we need to see in the world. It's going to take work on prevention. That's going to take you and me to make some lifestyle changes. It's going to take doctors being willing to talk about the necessary lifestyle changes, to understand that with all the changes in the world of Alzheimer's now, they can no longer say, well, why should I talk about Alzheimer's with my patients? Because it's not going to make a difference. There's nothing that can be done. There's stuff that could be done. We know there's stuff that can be done now. And with the new therapeutics, there'll be more things that could be done in the very near future. There's biomarkers that make their job so much easier. Key, though, is to have the conversations. And that takes us and it takes docs to make those conversations happen and then to make the changes. And it takes society at large. We can't individually behavior change our way out of the epidemic of Alzheimer's. It's going to take a lot of cultural supports for that as well. And we heard about that earlier today. We have to be able to detect and diagnose this disease. You can't fix something if you don't know it's there. That's going to take you and me, because we have to be willing to talk about it with ourselves, with our families, and then bring that to doctors. It's going to take tech. We heard about Us Against Alzheimer's project, mybrainguide.org, Brain Guide, a project that helps people to say, is this normal aging or is this something I need to worry about? And then getting the right information so that they can go to their doctors. It is going to take doctors. Doctors can't fail to diagnose this disease. Data shows that docs fail to diagnose it about half the time. That can't continue to be a thing. And it takes policy to support all of that. All of us have a piece to play in detection and diagnosis. And then there's treatment. We heard about the role of money in treatment, of venture capital, private money, of government money, of big pharma money, biotech money, lots of money to solve this big disease. And I'm going to come back to that in a second. There are promising results in this treatment. That is one of the big changes in our world with Alzheimer's. But it's one treatment right now, one treatment of one pathology. We think there's going to be multiple pathologies. There's not going to be a silver bullet, and people who are expecting a silver bullet are going to have a long time to wait. We should be excited about progress. We haven't had progress in Alzheimer's in 20 years. There are multiple causes to this disease, we think. There are going to be multiple solutions. We should be excited about steps along the way, just as they've been in cancer. We haven't had a treatment in Alzheimer's that costs any significant resources in years. And Senator Collins talked about the importance of patient advocacy. We're going to need to be advocates, doctors, clinicians of various sorts, researchers, patients, caregivers. All of us are going to need to raise our voices against a system that has said, hey, we don't really have to pay for the 6 million people with Alzheimer's disease right now. We just have to pay for the emergency room visits, the caregiving. So we do pay, but we haven't paid for a therapeutic directly, and that's coming. And we're going to need to advocate for that. So good changes have happened. More changes need to happen. As George said yesterday, we advocates are going to need to become more loud and more effective. I'm looking forward to where we can say changes have been made when we get together next year on all these fronts. Now, a few closing remarks. If you missed any of this, It's going to be up on the website as of tomorrow. We invite you to download, to review, to take clips and put it on social media. If you talk about this on social media, please use the hashtag USA2 Summit, Us Against Alzheimer's, USA2 Summit. It does take money to do this, and there should be right now coming up on your screen a QR code that you can take a little picture of, or put your phone up to it. And if you like what you've seen, if you like what you've heard, please support us. The work continues, the fight continues, the advocacy will need to continue. So please help us out and make us a donation. Finally, just to conclude, thank you to all of the panelists. Thank you to the team at Us Against Alzheimer's, all the people behind the scenes, with our production partners, everybody who made this possible. And thanks to you for tuning in. This has been a great summit from my perspective. I hope it has been from yours. If you have any feedback, let us know. Until then, we look forward to seeing you again next year. Thank you.